Welcome to this session of Excellence in Diabetes. My name is Dr. Maya, Medical Manager for English speaking for Sanofi and Attaining. So today we'll be discussing various topics, of course, in the realm of diabetes. We have various speakers and in association with KNH and KDSG. We'll be bringing you great insights from our great speakers this morning. We have Dr. Caroline Billy and Dr. Jacqueline Yambu. Also, we have Dr. Rosa Dodi. Then else, maybe Dr. Oliver Kunda, she's here to she'll be there shortly. So I'll start off the presentation by welcoming everyone online. We have around 500 people online. Thank you for coming on board. We have around 30 physically, and we really appreciate your attendance. And our company is really committed towards training and bringing continuous medical education to the greater healthcare professionals doing the good work out there. So I'll start us off by a small recap. We had a similar forum last year, and in the last forum, we had a session done by Dr. Wakunga on diabetic centers of excellence. And it's analogous, of course, to diabetic comprehensive care. So if you do have, or if you guys are running a diabetic clinic or a diabetic hospital, one of the key elements is attaining excellence in this sector. And we'll go through some of the documents in a very short presentation. And then we look at some of the aims. So the government released this document in the 2000s, and this was to help most of, if not all of the hospitals or clinics or centers running diabetic clinics for them to attain some sort of excellence. Right? So this still remains as a first edition. When you look at the document, it really doesn't need some revision majorly because most of the things that are written there are very well explained. Number two, it's in a simplified language, and most it's really geared for the most healthcare professionals and the local. So the aims are really to understand diabetic centers of excellence, building confidence in the HCP, engaging the patient well, monitoring evaluation, and then any program you have to monitor, evaluate, you have to sustain, right? So at the end of this session, we have an objective or seven objectives. We need to understand the concept of diabetic comprehensive care, the ideal composition of diabetic comprehensive care, essential components of diabetic education, importance of diabetic health record, right? We have points of discussion. So our discussion points today will be really discussing DM practice. And then we need to do a follow-up on the diabetic centers of excellence and diabetic comprehensive care concept, which most of the clinics have decided to adopt. And we look into a few of the case examples here physically from the attendees. There's a small picture there saying, I can control my diabetes by eating veggies, exercising regularly, and drinking water. But I'm holding out for better options, right? So this creates a lot of panic in the patient. One of the reasons why is because the doctor seeing the patient has not really given the patient the holistic approach or the whole care, multidisciplinary involvement, right? So we are moving away from thinking that just eating, exercise, and drinking water amongst other therapies are the real gold standards for treating diabetes. So we need to move back to therapies that actually work. And the Center of Excellence should be able to analyze this, right? Some small statistics, every 10 seconds, person dies from diabetes with conditions in the world, and it kills many as 3.5 million per year. About 90% of people with diabetes have the type 2, and mostly it occurs in 45 and above. Recently, we've been seeing many patients at the age of 35 presenting with diabetes, and some very late onset, right? Major complications we are seeing in the rise, especially we really have a cardiovascular disease right now, and many young people are presenting to the catheter with a need for their, interventions done. So most of the cholesterol issues are really the area. There's an increase, of course, in blindness, is kidney failure. We used to say when I was practicing, I think just out of internship, the largest cause of patients, of course, ending up in dialysis was HIV and heart treatment. Along the way, it became hypertension, and currently diabetes is taking the lead. So diseases are not really books. We need to be able to also adapt to the changes we are seeing. There's a lot of nerve damage, and most of this nerve damage is being caused by microvascular complications, and a lot of it is being caused by fluctuations in sugar. So we are not really controlling the sugar of patients as we need to do, pulling in excursions of the sugars. And a lot of amputations are still happening. We expect that at this rate, we will never have diabetic amputations as such. So we're causing a lot of disability in patients, and they're really stressing their healthcare services. They are stressing their employers. Of course, they are losing days. Right? They are losing income. And then we are really not improving the quality of life. So despite its multi-system effects, diabetes is a controllable disease, and there's unequivocal evidence that its enormous human and economic toll can significantly be reduced by early and aggressive ongoing therapeutic interventions. The principal clinical feature, of course, of type 2 diabetes is control what is, of course, in the definition of the hyperglycemia, which is really a leading cause of everything that happens to most of these patients. Any excursion, any increase in the sugar that is not controlled, any inertial treatment, we need to control the sugars. If the medication is not doing that, we need to escalate the therapies. We need to control the lipid issues, and then we need to control the hypertension issues. We now know there's a very strong link between the vascular issues caused by diabetes and patients entering into pre-hypertension and then hypertension. Then we have also the issues of metabolic syndrome. However, we need to know that these things cannot be successfully managed with sporadic, reactive, and episodic care. So what do we need to do? We need to put out, of course, a very structured approach. So if diabetes care is to achieve the health benefits that modern medicine has made possible, it must include continuous, not episodic reactions. We need to be proactive, not reactive. We need to be planned, not sporadic. Patient-centered rather than provider-centered, then population-based as well as individual-based. One system that incorporates this is the chronic disease model for diabetes and other chronic diseases, of course. Primary care workers actually provide 80 to 90% of diabetes care in the country. And today, most of the efforts to improve care for people with diabetes have assumed that primary healthcare workers can affect the necessary changes, and this is not the correct approach. We need to extralate, we need to consult as multidisciplinary teams, and we need also to refer when necessary to avoid patients standing in amputations and all the complications. So there's an interesting slide here. We call it the power of Kaizen. And this is just for any center of excellence, some of the things that they need to do. So we have 10 key principles that help a situation like this, wherever you're having a lot of challenges in healthcare. So the first thing we need to do is let go of assumptions. So we don't assume that, of course, our center is giving the best care first. Are we able to ascertain that with numbers? Are we able to ascertain that with quality parameters? Right? We need to be proactive about solving the issues that are affecting the patients. We cannot just, do conveyor belt medicine. We see there and patients come in and come out, right? So whenever you do a proactive solution, you need to measure the outcome, right? Don't accept the status quo. Just because every day someone is telling you 3.5 million people are dying annually, it looks like a good number to present in a session. Now, don't accept that that is what we are doomed to. So let's change these numbers. Let's get out of the perfectionism, take an attitude of iterative adaptive change.
there's a lot of changes in diabetes. Like we mentioned, the disease is attacking organs differently from the first time I started practicing to currently. So we need to adapt and also change our practice based on that. Then look for solutions as you find mistakes. Create an environment which everyone feels empowered to contribute. Don't accept the obvious issue. Ask the 5 whys, right? Get a root cause. So for any problem affecting a patient or a clinic, ask the 5 whys. Why are we not getting enough drugs? There's a certain clinic you went to, they say that, oh, one of the reasons why we're having challenges is because we don't have insulin. So we ask them, why don't you have insulin? They say it's out of stock. So we ask them, why is it out of stock? They say what? We don't know. So we ask the pharmacy technician, the farm tech. They ask them, why is it out of stock? Because these things expire. And why do they expire? Because the doctor is not prescribing insulin. Why is the doctor not prescribing insulin and the doctor is not ordered the insulin? So maybe it's an issue of training on how to use the insulin. It is a technical drug, you know. So ask the 5 whys. In every problem you're tackling in the clinic, why are patients not coming for renal function tests? Why are all our patients, none has ever seen an ophthalmologist, right? Why has the patient never been done for an ECG for the last 10 years and is on diabetes medication, has been diagnosed 20 years ago, I've never had an ECG? The question is why, right? And make sure you reach the 5 whys. Carry information and opinions from multiple people. Make sure that the information right now in an age of a lot of fake news and fake information. So let's carry it out and give the correct information. Use creativity and innovation to find low-cost, impactful solutions that really require small improvements. In the clinics, you can actually improve a lot about the patient by starting to talk to the patient. Right? Then you discover, okay, this is a pre-diabetic, this one is now fully grown diabetic. These are diabetic with hypertension. So analyze your whole patients. If there's a patient who is tipping over to hypertension and diabetes, are you able to intervene? Make small improvements in the patient's life. Make small improvements in the clinic. Are they able to screen? If you have this knowledge, you go back down with it and really exert it on the clinic. And lastly, the basis of Kaizen is continuous improvement for life, right? So you never stop improving. This is a very interesting slide that I saw the team members at diabetic care center, where you expect there's a comprehensive approach. You just go through it in like 2 seconds. You see that you cannot manage this patient alone. So if your clinic is managing this patient alone, you're really doing the wrong thing. So you need to have, for example, a diabetologist or an endocrinologist. Initially, we used to manage, I think when I was working, we used to manage like around 600 patients alone in the patient, chronic clinic. And then you found that you rarely used to consult with any endocrinologist or diabetologist. So you miss out on a certain therapy for the patient. Then you don't know if the patient is still alive till to date. Maybe the patient went out with an MRI. Most of the patients we noted that are coming in with chest pain and have been given medication for maybe heartburn, right? Or just allergic reaction. But then actually the patient has a small MRI and then it converts to a big MRI and you lose the patient, right? So some of these things are really important for you to consult, right? There's another patient who came in and said that he just had a sudden feeling of a headache with small dryness, then he recovered. The patient has a very micro stroke, and then you let the patient go home and okay, thank you, Jesus, you are alive, move on with your life. But you never took the patient for further cardiovascular screening, right? Talk to health educators, right? And then talking to the PhD team, I think one of the things they really focus on is diabetic educators, which is one of the key cornerstones of any diabetic. If you're not a diabetic educator, even if you're a medical officer, they're being poor, right? So you should take a course on diabetic education, right? It might look an easy thing that you don't add anything to value to the CV, but it will add value to the patient in your clinic, right? So laughter is the best medicine. Well, unless you are diabetic, then you have to get insulin at some point. I think we were told that there's a beta cell decline. I think Dr. Carol maybe always sees this thing beta cell decline at 4% annually. I never forget that thing. Yeah? So someone told me that eventually, when you actually are diagnosed with having diabetes, you lost 50% already of beta cells. So you cannot throw out all that knowledge and assume that the patient is okay. The patient has already lost 50% of their beta cells. Then by seeing you've added to their loss, or you've improved their loss, or you've given their beta cells some holiday, right? So you can use therapies to actually avoid exhaustion of beta cells, right? So whenever you have the metformins and all these drugs actually have effects on the beta cell. But do we know? So we don't know, right? Everyone knows what insulin does, but how does it affect the patient, right? So we need to learn actually need to learn our therapies well for us to prevent complications of disease, right? If someone says this drug reduces HbA1c by X and Y%, try to believe them. Yeah, they might be correct. But the patient is not only HbA1c. The patient will come with erectile dysfunction. The patient will come with a history of chest pain and MI, right? So the patient will be having very many complications of the disease as so screen all the complications, right? You need to do patient education. You can't educate a patient if you're not a diabetic educator. Let's not lie to yourself, right? If you go to Ethiopia and tell them stop eating red meat and 90% of people eat red meat there, you're going to be educating the wrong people. So it's very good to get the right education for your diabetic patient. The basis of medicine will always be follow-up. You cannot see a patient once and assume you've seen a patient, right? You need to see the patient's journey with the disease, right? For you to always say, okay, I'm able to store kidney loss function in the patient. You're not just seeing a patient for the sake of seeing a patient. There are complications you can verify. There are patients who tell you have erectile issues. You're able to correct that. The patient will tell you have nerve issues. There are patients who tell you have loss of sensation. How are you able to tell this if you're not even doing a physical exam on the patient? You're not using a monofilament. You're not using. The last time the doctor told us he carries a filament in the bag just to check for protecting the reflexive, right? Do you still use a pattern hammer or it's causing damage to the patient? Right? So some of these things are really important. And I think we need to go back to them using the monofilament. The pattern hammer used to have the filament at the end, right? So how do you test for light touch and all that, right? Then deep touch. So how do you know this patient has neuropathy just by looking? You have to actually do some assessment, right? Then any patient who sees a doctor, a clinician, a HCP, you must improve their quality of life, right? The same way your phone has improved your quality of life from sending a letter to your loved one. Now you can send a text message or a TikTok video, right? You can also do the same with the patients. Improve their quality of life when they see you, not reduce their quality of life, right? One of the things we get when we deal with something called treatment inertia is patients that I've been seeing this doctor for 5 years, and my condition has remained either the same, is just getting worse. I just continue seeing him because the doctor is not really improving the healthcare of the patient. So please improve their quality of life. One of the most important things in healthcare right now is the merging of therapies and everything else with business. So you need to reduce the costs of treatment on these patients. For you, failing to notice that this patient is going to have a progression of loss of beta cells does not prepare you for the future. All patients, I think one of the doctors here said, the first time you see them, you start by also canceling them or eventually lead on insulin, right? Till we get a cure for diabetes, then we don't have any other pathway. All outcomes will be you to insulin, right? So you prepare the patient in advance, right? You also notice that if this patient has 5 drugs, has another 10 drugs, tension, maybe he also has arthritis, he also has issues in his prostate. I mean, you can give insulin and reduce the number of organs, right? We don't have to have a patient having 10,000 drugs as a basket going home every day, right? Always remember we need to reduce or prevent future complications of disease. So this makes up, of course, the role of a clinician in chronic disease management. And the ideal clinician should be able to know, they should have knowledge. They should attend CMEs and congresses for them to get knowledge. Number two, their practice. If you go to any center of excellence, they're not using guidelines, there are no standards of care. There are no patient rights, there are no patient responsibilities. The patient's rights include, of course, the right to treatment, but the patient responsibility includes the advice you give them, they must take it, right? If you're told something by the clinician, it should be there, it's written on the wall, that these are the rights, of course, you have, but these are the other rights of the clinician. If I tell you you need this, and eventually your disease gets bad because you've not taken my advice, it is the responsibility of the patient that is paid, right? Proper history and physical exam we talked about. Treatment guidelines, I think one of the presenters will give us updates on the treatment guidelines. They're working on the treatment guidelines for Kenya. Protocols and algorithms are very good. Flow sheets within investigations are very good. Screening in almost all centers should be done. So I don't expect a clinician to not screen. So there's a clinic I went to, they say, we don't have a screening program. It's not supposed to be a screening program. It's supposed to be any patient who comes, there's a nurse who will go to screen, right? You know the blood pressure is high. You know their sugar is high, right? You know their HbA1c is high. You don't have to say you need a screening program. You can move on to the renal function slow, right? Send it to the right consultant and you're not able to work with it. Working in interdisciplinary teams, we talk about integration, you'll be able to refer. You cannot work alone with a diabetic patient. So whenever you have reached your limit, you can actually refer, right? Continuum of care. A patient is not an endpoint. A patient is a journey you have with them, right? The checkups they have and the follow-ups they have. In the future, they're saying many of these things will be digitized, right? Digitization doesn't mean patients care improved. I have a patient who I've seen on CGM, right? But all these sugars all over the place. Just because you can tell they're all over the place doesn't mean you intervene on anything, right? So you need to think about that. Even if we digitize sugars and the patient's sugars are still all over the place, you've not really done anything. You need to institute therapy, right? So you need to be impactful and then give correct, realistic therapies for the patient. So we can overcome inertia, we need to monitor and evaluate. So we need to monitor and evaluate things that we're doing. Go to your clinic, ask for a record of how many patients have not changed their therapy in the last 10 years and why. Then look at the parameters. Very simple. Why have they not changed their therapy? Have they not escalated? You're talking about a progressive disease. So sometime in their life, their therapy should change, right? Look at your health records if they are okay, right? Are they really recalling what is supposed to be recorded in that place, right? Evaluate outcomes of team care and then determine future progress. And then indicating team success in meeting quality measures. For this, you need a quality team led by, of course, a clinician and periodic meeting, right? Patient satisfaction, quality of life, interviews or questionnaires so patients can provide valuable feedback to the team and influence the scope and quality of care provided. You need to have a dynamic delivery system whereby you can measure the inputs, outputs, outcomes, impacts. For example, if you go to outcomes, positive lifestyle change, improved quality of self-care. Go, like we say, doctors now, the gold standard people are talking about is self-monitoring of blood glucose. Just because they are monitoring the blood glucose with the CGM doesn't mean they are really getting their targets correct, right? So, yes, they are monitoring, but have you improved their self-care, right? Then improve quality of care, right? Impacts are always simple. The first impact of healthcare is to reduce death, right? The rest is to reduce morbidity. Overcoming patient obstacles in care, you need to be educated in counseling a diabetic patient. One of the gaps we had when we left internship was you were, of course, I will not say thrown into the line, but you're told, okay, you're going to leave the patient. How do you counsel a patient who has lost a pregnancy? Right? You are not told about counsel a patient who has lost a pregnancy. How do you counsel a patient who is the first time they are seeing these sugars this high? You just tell them, oh, now you are diabetic. You're going to shock the patient. And patients now have rights and feelings. You don't go around telling patients, now, from tomorrow, you are hypertensive and you need medication. Patients nowadays don't want to be called hypertensive. They want to be called after living with hypertension. So you have to know their feelings, right? Knowing their feelings doesn't mean you should accord it, right? So you have to tell them everything that deals them. You have to educate them about what the disease will do to them, right? The education focuses, of course, signs and symptoms, sugar monitoring, insulin doses, use of appropriate syringes, medication adherence, nutrition. Diabetic education still talks about the food care. Whenever we move around, we see there's a lot of problems with food care. I think during my medical days in the campus, we were assessed by, of course, in IMED, you're told to assess this patient, right? So you are there, you're being looked at by all the registrars, and a diabetic patient, you start analyzing them from the feet. If you don't, you tend to fail, right? So you need to start examining them with their feet. What's wrong with their feet? Their foot care. Are they wearing the right shoe size? Do they have cones? Do they have, peeling of skin in between the interdigitals? Do they have fungal infections? Some of them come with so much fever. You give them all the antibiotics, then you look in between their clothes, they have a lot of fungus, right? So, I mean, some have holes there, some tend to not protect their feet with socks and appropriate heels. Some tend to have calcaneal spars. So we really need to look at these guys' feet, right? Eye care, I see that even now the AI guys have formed an app that actually can check the eye care for you. So that being said, I don't know if Dr. Roslyn still uses your otoscope in the clinic.
We try.
Okay. Then psychosocial issues always have to be managed. You cannot manage psychosocial issues without some counseling training. So I believe everyone who's a healthcare professional should have a basic counseling training, right? So this is what we call a scapegoat, and the scapegoat is blood sugar. Now that's the problem with diabetes. Everyone thinks blood sugar is the end and beginning of diabetes. Please, there are other things you can record in the patient. We mentioned is the HbA1c, the renal function, cardiovascular disease, total cardiovascular risk assessment. You can actually calculate the survival rates. I mean, you can even locally, you can even score your patients. How many have ever seen an ophthalmologist? How many have ever seen a renal physician? How many have ever seen a cardiologist if they have the complication, right? You cannot improve what you cannot measure by exercise. Some of the basic tests, I don't call them basic, but I call them tests you can do. They are of course summarized in the diabetic comprehensive care manual, so you can just go through it later. It can be posted in the chat. Check on the outcomes: leg amputation, stroke, blindness, end-stage renal failure, and myocardial infarction. And by that, you need to know the incidence in your clinic. So everyone in this room and online should be able to tell us what is the incidence of all these outcomes in their setting, right? In time, we hope that Team Apple will give us an iPad where it actually measures your sugars and controls it for you. But that is being lazy. So doctors cannot be lazy and wait for the iPad. Please control your patient's sugars. Fix their fasting. Their excursions during the days can be fixed with medication. So please do that, right? You can actually give patients a longer days on this planet by fixing their excursions of sugar. There's a presentation, I think it was done by Dr. Rose, which told us by the time you are seeing a patient, these guys already have microvascular complication. So your job is now to prevent the micro, right? One thing is that the big vessels really take up a lot of sugar and predispose these guys even eating worse, atherosclerosis and all that, right? Please always check at least their ECGs. all patients with diabetes should have an annual ECG, if you ask me my opinion, and it should be a policy in every clinic. They should also have their renal functions checked. Those two at least we need to do, right? Patients should know their cholesterol, patients should know their HbA1c, and one of the most important also things that patients should check. Really, we never say this is their waist, right? So in any clinic, we always hear weight, and BMI. But you know, BMI cannot be really reliable, right? If you're coming from Western Kenya, so you guys are all big, your BMI is going to be high. But are you really over? No, because you're tall and heavy, right? But if your waist size shows wealth of your previous generation, you need to do something about your waist, yeah? So I think there's one, I think there's a research that was done on waist sizes some time, it was exactly in the last session, whereby the waist size really corresponds to your cardiovascular risk, right? So waist should be taken. I think the government should donate tape measure for the waist for clinics with a glucometer. So we need to measure the waist. End of my presentation. Try to remember, sometimes the pancreas is just lazy, not sick. So find out what is causing the problems in the pancreas. There are other causes of that sugar to be high or low, the steroids or anything else, right? Thank you for your presentation. Okay, there are questions online. Please post your questions online. So, is there a role for palliative care clinician in the team considering the chronic nature of diabetes and associated comorbidities? I think I'll post this to Dr. Jacqueline. As we move away from glucocentric approach towards reducing overall cardiovascular risk, how do we reduce the costs and the newer drugs are very costly? This one I'll give to Dr. Carol.
Thank you. For that question, is there a role of palliative care clinicians in the team? There is a big role for palliative care clinicians. We always think of palliative care mainly for cancer patients, but we forget diabetes patients have a lot of comorbidities. Some of them have end-stage renal disease, some of them have end-stage heart failure or other diseases that are end-stage. And with that, the palliative care specialist comes in. So there's a big role for the palliative care specialist in diabetes control and its associated comorbidities. Then the second question, as we move away from glucocentric approach towards reducing overall cardiovascular risk, how do you reduce costs as the newer drugs are a little costly? So that should have been Dr. Amaya's question because they're the ones who do the drugs. But I think also when you're thinking of the drugs, we find the role of combination pills, which sometimes end up being cheaper than doing the pills on their own. And now even with the injections, you're getting new injections that are combination therapies. So that helps with the cost. Then as the drugs are in the market longer and longer, and Dr. Amaya and company becoming more generous, we hope with time there will be a role for reducing costs. And then there's also the issues of taxes and the government coming in to help subsidize the cost.
So one of the best approaches is that we have access programs of various companies that try this and reduce the cost in existing therapies. My lovely colleague has failed to mention is that the therapies in existence still work on patients. So let's not assume, let's throw out all the drugs that are in existence for the new drugs. Yes, patients have not been exposed to them, right? So there's a tendency to run to newer therapies, yet all therapies have been working, and which are really, what is the cost of metformin showing? What is the cost of metformin? 1,000. 15 bob. In government, no. 1 bob. Yes. It's 1 shilling government. So if you're in the, I won't say group, but in the, diasporial counties. So please note, don't force patients to buy expensive drugs and you're not even able to monitor these guys' sugars, right? Let's start by correcting the sugar. Metformin, what is the highest dose you can give a patient? Anyone? 2 grams daily. And you're already starting them on before in Lokichokyo, I'm just looking at small allusion. So I'm just saying that don't deny a patient's therapy, don't deny a family income because you want them to be on the best track, yes, but they're not able to afford food and all that, right? We already know that our economic situation is not really good in the country, so let's not force patients to not take drugs, right? So I will invite Dr. Carla Njeri.
I think we can answer that question in subsequent. I think Dr. Rosie will talk about that in our guidelines. So I'm in there. We can have my presentation. Thank you guys. It's good to see you. Always a pleasure to come back here. I am passionate about medical education. And yeah, just telling you what's new. I've given a very difficult topic, numbers. I do not like numbers, but then here I am. So I'll try and make it as relatable. And Amaya said something that was, very important. You cannot improve what you cannot measure. We need to know where we are at. Why is diabetes? Why are we here? Why is diabetes such a big thing? And what to do about it? And then at the end of the presentation, then I'll ask, okay, fine, we know the numbers. So what do we do about it? So who knows the leading country in the world with the highest prevalence of diabetes? If you know this, I'll buy you lunch today. Let's wait for highest. Sorry? Take a guess. Yeah? Someone say it. Yeah? No, Kenya, no. Kenya, we are the 38th in Africa. We're doing well or we don't have data. Anyone? Take a guess. After US, you guys. Seems a little, I think it's not US, it's actually China. Yeah, rural China, not even urban China. Okay, so diabetes, it's actually just a T. Is there a way to lower or that's how it is? Can I remove the top parts? Thank you. So diabetes is what you're feeling right now is just a tip of the iceberg. Usually say at least 2/3 of people. Thank you. Thank you. So more than 2/3 of people with diabetes in the world are undiagnosed. So the number of people you see in your clinics, remember there's a whole iceberg down there that are not diagnosed. So the question that I started with, why do we care about diabetes? Why are we here? You'd be surprised. We all know HIV kills, TB kills, malaria kills. Diabetes actually is one of the leading causes of death is due to the diabetic complications, okay? So look at that. This was in 2015 by the IDF, International Diabetes Federation, 1.5. I see my senior ID fellow, as you. Yeah, HIV, 1.5. I read the numbers have changed. TB, 1.5, probably instead of the new numbers. But what I'm trying to say is diabetes is high there, especially because of the diabetic-related complication. And how does it kill? So diabetes in itself, yeah, unless you have like a diabetic emergency, like a DKA, you can die. But diabetes is a very slow killing disease in terms of complications. Complications are the ones that will kill you. And so the reason you need to know the numbers is how can we first prevent you from getting diabetes? If you have diabetes, how can we screen? And then how can we treat? How can we, so where can we catch you? So it's the leading cause of cardiovascular death, kidney failure, blindness. Look at that. 50 to 80% of people with diabetes die of cardiovascular disease. That is big. Like 8 out of 10 patients that you see in clinic. If we don't do anything, if we don't intensify, they'll actually die of diabetes, of cardiovascular disease. 44% of patients have kidney failure. I'm happy to actually go talk about that. Yeah, so 4 in 10 patients with diabetes will have CKD. And so we have to do our urine microalbumin at the point of contact with this patient. You have to do an analysis, check proteins, start on an ACE inhibitor for these patients to just prevent and all the other neuromolecules that Rosie will talk about. 60% of amputations occurs in diabetes. It's not only does it kill, but if you stay alive for longer, you'll have, comorbids like amputations and etc. What does that do to your quality of life? And Rosie will talk about the new things in guidelines is that we're no longer, talking much about glycemic control. Very happy with that. Our goal now is quality of life improvement. It's key in these patients. So 16% of people die of stroke. I usually joke and probably the team from I can't worry, I know I probably have been a neurologist in my other worlds, but I'm passionate about stroke. So this is key, especially in patients with diabetes. And then 29% of people have diabetic retinopathy. So the reason why we need to know about diabetes is because we can prevent these complications. We can improve the quality of life in these patients. Now to the numbers, stay with me, hang in here, guys. So this was in 2021, idea, 587 million patients are living with diabetes. Okay, what does that have to do with what growing in Ghana? So really, it's in our lower and middle income countries, 3 in 4 adults live with diabetes. That is big, you guys. Look at your neighbors, just count 1, 2, 3, 4. You guys, it's scary. Yeah, so 1, 2, 3, 4. Please choose the one who will have diabetes. We have to do something. It's an epidemic. We have to. And it's worse, it's bad in our country, low and middle income. Very many numbers, but just look at that. 1 in 10 patients have diabetes. The 3 to 4, 3 in 4, that was in low and middle income, and we'll look at the numbers in Africa. But 1, 2, 3, 4, 1 will have diabetes. We pray that it's not us, but we don't only need to pray, we need to do something about it. 1 in 2 are undiagnosed. So the 1 in 10 are those who we know will get that. 1 in 2, 1, 2, you don't know you have diabetes. So you have to screen. And you have to screen at what age? What now is the age of screening for diabetes? Who knows? This lunch. Okay, for 10 o'clock tea. Lunch is far. Yeah? 35. Yeah, a deal. Good. So it's actually at 35. Majority of us, I want to assume they're more than above 35. How often do we screen? You need to screen at 35, and then every 3 years, if you do not have the risk factors that we'll talk about. Yeah. Then now, it's not only diabetes. Now we are able to catch it early and give even metformin or something that we say, we can do something about. If you have pre-diabetes, and how do we define pre-diabetes? We are able to test if you have impaired fasting glucose or impaired, actually, HbA1c glycemic control. So if you have an A1C of 5.7, we do A1Cs, you do A1C and you have 5.7, like, cheers, man, you don't have diabetes, but that person has pre-diabetes. There are treats. They just need another 3 years, and then they'll cross over into diabetes. If you have an impaired fasting glucose of 7 or whatever, 6.9, yeah, don't say bye-bye, see you. Send them to a nutritionist. Tell them all the lifestyle things that they need to do. So we've already talked about 3 in 4 people with diabetes living that. Okay. Please, I want you to note Africa down here. Look at our rate of increase, you guys. 129% increase in diabetes. That's how rapidly we're increasing our rates. You know how we knew about the USA? No, that's slow. Those ones have gotten away. It's just North America, 24% increase of diabetes from 2021 to 2045. Okay, that's in like what, 20 years to come. Yeah, Africa, we are competing with not even the rest of the world, with ourselves, you know, to see how much we are going to accumulate diabetes. And why is that? Look at our diet, look at our nutrition, look at our smoking, alcohol, you know, everything is just plaguing us. If it's not the floods, we'll die of something, you know, maybe not that we die of diabetes. But the whole point of this was, look at Africa, 129% increase. We have to hold still. We have to reduce the rapid increase of diabetes in our country, in Africa in general. So for the purpose of this, I want to assume we're a middle income country and not a low income country. Sometimes we, you know, we usually say, if you want funding, we say how we don't want to school in shoes, how we are low income, but if not, we're okay, we are middle income. So look at the pink line. So we start off at the same place, 20 to 24 years, okay? And then now, when we get to 40, now we rapidly increase our prevalence of diabetes because that's where we get to, and then now we settle off. So the whole idea of is we have a chance to do something 35 years, or before we get to that 5 years, yeah, we have a chance to slow down the progression of diabetes. Number of people living with diabetes, as we all know, the urban population between rural and urban, chips, to do fries, whatever. Look at just down Limuru, I actually counted how many, what are they called? Not banners, those things that attract you. Billboards of food, you know, this KFC, they produce out some sauce, some nice sauce, and it's so good, and it's cheap. You know, fast food is cheap in Kenya, and that is where we are getting our diabetes from. From children, even as young as, you know, 10 years old, they're already obese because that's what they see. Yeah, that's what's being advertised. So urban is going up. So for lunch, China is leading with diabetes, which is interesting. Look at the body morphology of Chinese. You know, they're not like Indians, they're not big in terms of body morphism. They're almost small, where are they getting diabetes? And then it's interesting that it's mostly the yellow is rural, the pink is urban. Yeah. So most people in rural China should have diabetes. It was just that good to know, you know, those things that in the summer, then you have some spare mind space to see. USA, as expected, the urban is more. As we are almost like under that, we are doing well relatively, but we know, and that's why I mean KDSG with Akina Rosie and the team, they're doing such a lot of work. We need a database of our patients with diabetes. That's why you're in Shogyo, and you see a patient with diabetes actually able to log in, and I can assure you the numbers are crazy. We've talked a lot, and what I've shown is this kind of patients with type 2 diabetes. So patients with type 1 diabetes, we don't have data. We're actually not coming up, and look at Kenya. So if it's gray, means we don't have data, no estimates made. Kenya is actually among somewhere in the gray, we don't have data for that. So we can't talk much about patients with type 1 diabetes or patients with adult onset and diabetes 20. So Africa coming, now we've seen the world, we've seen globally and why we're having it, but then in Africa, I mean, the numbers are, and this was a 2019 estimate, that we have 19 million people already have diabetes, but then you'd be surprised, the 2015 IDF survey showed that we actually have now 25 million people. Like the numbers are just almost doubling as they go. So what's our Kenyan statistics? Where are we at in terms of prevalence of diabetes? I have to say that we actually extracted this from the International Diabetes Federation database because they have statistics of every country. And this was in 2021, 3 years ago. Here, interesting, we're not 27 million people. I don't know, anyway, we are seeing that in terms of adults. I know we're around 50 million Kenyans, but this is the adult population that was captured at the time. And they gave a prevalence of 3.3% prevalence of diabetes. What does that tell us? 3 in 10. I'm 1 to 3 to 10, God forbid. may have diabetes. And so we have to do something about this. And this is the people who are known. Yeah. In Africa, how many people? 24 million people in the African region right now living with diabetes. But in 20 years to come, will be 55 million. You guys will have doubled that number in 20 years. We have to do something. We have to do something. So this is just like a glance, and it just tells us how the numbers are rapidly increasing every 10 or 15 years, and that's just the top part. We are literally doubling. That's what you need to know. And you can see from the graph up. And at some point in 2021, there'll be a sharp increase. Okay, so fine. I'm working with the numbers. So what do you do about that? Yeah, so we are 3.3%. So what? Key thing, we have to reduce our risk. If you take nothing away from this, our goals, one, can we prevent development of type 2 diabetes? We have the modified risk factors, something we can do about, and something that we cannot, and we'll talk about that. Early screening and diagnosis at 35. Have we told everyone who's above 35 to go for screening? Who are the people who will offer screening even at a younger age than 35? Yeah. Then, if you find patients with diabetes, we should do early intensification of these patients in terms of glycemic control. If you get a 35-year-old with diabetes, be as aggressive as you can to give them a good A1C. And that's because one, there's something called the legacy effects. 20 years down the line, the intensification indeed will really help. And it's been shown that the glycemic control is better, if you started off well. But if you're like, let's, drugs are expensive, let's do, be as aggressive as you can. You'd rather taper down at some point. And then the overall thing, we all want to live a day longer, if God wills. Let's prevent complications, give them a good quality of life, and prevent death. So this is the goal of this talk. Why do we want to know the numbers? So modifiable risk factors, things that we can do something about. Physical inactivity. How many minutes are we needed to exercise, especially for patients with diabetes? How long will you tell them? Yeah, Jerida. Jerida is our diabetic nurse educator and excellence nurse. Yeah, 150 minutes a week. So that translates to 30 minutes a day. So you can tell patients, just exercise 30 minutes a day, Monday to Friday, because when you tell a patient exercise 150 minutes a week, you shouldn't be left wondering, but you tell them, break it down, 30 minutes, how's your schedule like? That's important. Overweight and obesity, this is one, and we'll look at our Kenyan statistics in our study that was done, what are our Kenyan risk factors to developing diabetes. So obesity is very high, and overweight. 3, poor dietary habits, our fast foods. And this is just foods laden with triglycerides and LDLs and whatnot, So those are things that we can do something about. Let's prevent diabetes. Hypertension, early screening of hypertension, early treatment and management, reduction of salt, exercise, just what we say. Smoking, and now interestingly, our Kenyan data, we found that alcohol was also a contributor to developing diabetes. There are things that we can't do anything about. Males, gender, all the males here, you're at a risk of developing diabetes. Usually say women outlive men. Family history, if you have a family history, one with diabetes, a first-degree relative, or you've had gestational diabetes, then you're also at risk. But you can't do much about that. But we'll talk about how then we can screen and prevent, especially if you've had all these. If you're above 45 years, you're at a higher risk. If you are Black, we are all Africans, I want to assume, or if you're Indian, African, Latino, and we look at those, you're at increased risk. We can't do anything, but we can do something about our lifestyle. We can do something about our nutrition, exercise, obesity, those are things, stopping smoking. So this is, it's almost relatable to what the world should. Here we look at the three factors, including less than 0.001. or 005, that was what they used. So second thing, waist circumference obesity. So we know that obesity was clinically significant to developing diabetes. Also, just your cholesterol, and cholesterol is in different parts. So your low HDL is a good cholesterol you want people to have. And then now you have your bad cholesterol, the triglycerides, the LDL, those that cause strokes and heart attack will predispose you to that. So, and that will come also in terms of food and everything. The other factor that they found was, it's all bad fats, low HDL, high total cholesterol. That was important, especially in our Kenyan population. So, okay, so we've known one, reduce your risk in terms of modifiable risk factor. Two, how are you at risk? Even with patients, ask them, are you at risk? This is, I'm sorry, it's not too clear, but I'll explain that. So the ADA found that if you actually administer these questionnaire to every patient, for every person coming, you're able to catch them or reduce their risk. And so what they tell you, how old are you? So it's in points. Are you a male or female? If you're male, 1 point, because you're at a higher risk. If you're a woman, 0 points. And if you're a woman, have you had a history of gestational diabetes? Then you say yes, that's 1 point. Do you have anyone in your family with the history of diabetes, first degree? If it's yes, you're at risk. Have you ever been diagnosed with hypertension? Are you physically active? So it's something that you can even administer as patients are waiting to see. If you score higher of 5, then you're at risk. Okay, so you've identified who's at risk. So how do we screen? Remember, we started by saying, 1, testing should be considered in adults who are overweight or obese. Anyone who has an A1C and I mean a BMI, and I know we've talked about how BMI is not such an accurate measure. We'd rather use the waist circumference, but let's use what we have. A BMI of about 25, that's overweight or obese. And you have any of the risk factors. You just need overweight and any of the risk factors. And as we talk about that, look at yourself. Kendani. Okay, so, well, do you have a past degree in diabetes? I do. High risk, I'm already an African, too. History of CVD, thank God not. History of hypertension. Do you have a high cholesterol? Most of us don't know. Do you have PCOS? Are you physically inactive? So you need either 1, you have obesity plus any of the risks, okay? 2, who are the people we screen? We actively screen. If you have pre-diabetes, if you have an A1C of about 5.7, test that person yearly. Because you remember we said it takes 3 years for development of full-blown diabetes, if they don't do anything about it. 2, if you have had GDM, then it's lifelong testing for 3 years that you have to do. And then for all other people, if you're above 35, testing every 3 years if your results are normal. But if you find that you have pre-diabetes, you test how often? Yearly, okay? And then definitely people with HIV, and it will tell you that higher probability of diabetes. So children, especially now, and they have to introduce this, and that's because we are seeing young children at puberty, 10 years, who are severely obese. And we are actually even seeing children who are 10 years with type 2 diabetes. It's no longer type 1 diabetes, they do all those, and that's because of our lifestyle. So who do we screen children? How do we screen? So screening should be considered in all youth who are overweight or obese, who have had 1, they were born with GDM in the sense that in a mother who had GDM, or they have a maternal history of diabetes. So those you have to screen at 10 years. 2, if you've had a family history, first, second degree relative, majority now the Kenyan population. If you're African, in our country, it goes without saying, if you have other features of insulin resistance, okay? And I am done. I will talk about, and the rest of the speakers will talk about glycemic intensification and treatment and how to do that. But my take home is, now that you know better, do better. Yeah, that's the whole essence of knowing the numbers. We know it's an expert epidemic, we know it kills, but you can do something about it. So those things that you can do something about, take it back to your facilities, let that be your narrative. Yeah, now that we know better, do better. Thank you.
Thank you, Dr. Mipi. I think there are some questions online, but before we go to those, are there any questions on the floor? And as just to let you know that the youngest person with type 2 diabetes is actually 4 years old. So it does happen. Yeah, Dr. Ngugi?
Thank you for that excellent presentation. I just had a question in terms of screening, and this is something we are even discussing as with the Ministry of Health and KDSG, that we say, you know, there's a certain age, like above 35, you should start screening. Okay. So the question is, I usually tell my students and when I'm giving these talks that maybe perhaps at every opportunity we have medical officers, we have nurses who are seeing patients as the first point of contact. So don't you think that a patient who's come for a basic URTI looks obese, then you'd want to do a random blood sugar? I usually tell them any pregnant woman who just walks in for a regular checkup and has the flu, and we at that point do. So should we have specific set points? Because the issue has always been the cost benefit analysis. And if our basic random blood sugar is 200 shillings, I'm thinking if we are focusing more on prevention of diabetes, isn't it cheaper to actually screen the whole population at every chance that you get, rather than looking for specific risk factors? And that's when you screen.
So I'm agreeable with you, Dr. Rosie. We need to screen patients at every point of contact that we get. I'm in total agreement. And now, with the community health workers, I was actually impressed to know that they are walking around with, over and above the blood pressure measuring machine, they also have a blood glucose monitor. You know, as much as we want to crucify, you know, that aspect of primary prevention, I think that's an excellent thing, because you will get patients that way. Screen at every point of contact, more so if you're above 35, if you get a patient who's above 35, and also if they're obese or overweight. Okay, so we have to go the extra mile and do our measurements in terms of height, weight, and waist circumference if we can. I'm agreeable, but take home, check and pass point of contact.
Thank you, Dr. for the very patient presentation. I had a question. You put up a very staggering figure, 1.9% for cases that do you think it's a huge increase in number of cases, or are we detecting more cases? Are we actually having a big shift in our lifestyle?
That's actually a good thought. One, it's everything you say. One, we are testing more. Two, we are documenting the cases more. And also, three, there is great urbanization, especially in Africa. People are moving indoors. What is the easiest move to have in Africa? You know, it's actually now our lifestyle. And then we are more sedentary, you know, compared to our forefathers, if I want to call them that. And then also we smoking, alcohol, vaping, etc. You know, like it's everything that you say. But it's just like the concept of cancer. Why are we having such big cancer? Well, like, yeah, because we're testing more and we're recording more, but also our risk factors are also is everything. Is it a true reflection of our increase? I think we have to wait 2045 to see, but we think that yes. And that's why they're bringing the numbers to say, you guys, you have to do something, you have to stop. Because you're going to die as a country. We didn't die of COVID, thank God. You know, we shouldn't have non-communicable diseases. So it's everything to say, you're right. Yeah.
Okay, I want to ask, you've talked about currently the numbers stands at 24 million. And in the next 20 years, which is likely to be around 2045, the numbers would have risen to 55 million in Africa. Now, my question is, when you see the global statistics and the World Health Organization, including the US response to global epidemics, the numbers are usually reducing. For what specifically, what factors were specifically used to say that the numbers will be increasing? Because I tend to believe there are supposed to be improvement on research on the drugs to be used in diabetes. Should we say by then or going forward, there is lack of improvement in research for the drugs, or the bodies of those people who are susceptible to this diabetes will fail to respond to medication, or it is pegged on population increase? What could be the reason why the numbers would be will be rising instead of reducing?
That's a good question. So this is prevalence of people with diabetes. Prevalence means the number of people who will have diabetes by then. So it's not related in any way whether they'll respond to medication or not. Yeah, we know that with every year there is new medication, there's excellent medication nowadays for diabetes. But then we're not even looking at whether they respond or not. Yeah, because we haven't looked at mortality to see these people who die of diabetes. We're looking at how many people will actually have diabetes. And this is a trajectory. We are now going like this. And then now we're trying to go back and up. And why is that? And what can we stop, or how can we prevent or slow down the progression? It's not what we say. Let's look at our molecular disorders. We already know what can cause diabetes. Then let's get people moving. Let's eat well. Let's stop smoking. Let's stop alcohol. So the first step is knowing what's causing, then is that something we can do something about. Okay, then the people who we go with it, then we go look and see, okay, now can we actively not look for people? Can we screen at any point of contact? Can we screen at people who are not even sick? Okay, then we contact the second step. And then now we're like, okay, there are already people living with diabetes. Now can we intensify their control so that we prevent the progression and then, okay, so we've gotten them. Then at that times we do that. So it has to be very stepwise, definitely first prevention, and then we move backwards to now the people who already have diabetes. Can we intensify? Can we treat to prevent complications? So why the trajectory is rising? One, I agree with you, there's great population increase, urbanization, but also key thing is our lifestyle is deteriorating at a very fast rate. Yeah.
Okay, I'll go to the questions online. Some of the questions you've asked will be answered by the next presenters. So some of those questions I will skip them, but there's an interesting question here from Viona Mushene. So glycemic control is not a focus, yet we are told that drugs only slow down the rate of diabetes complications and that they don't completely retard the progression to complications. So when we talk about improving the quality of life, what parameters are we really addressing if glycemic control is not a priority?
Rosalind, will you talk about that? Yeah.
Dr. Rosalind will talk about that one.
Because and that's because right now, glycemic control is big. It's still big, yeah? Because if you control your glucose, then it will prevent complications. But then we are saying that's not the only thing now in diabetes management. We are going over and above to preventing cardiovascular risk factors. That's the big, because we've seen 50 to 80% of patients with diabetes will die of cardiovascular disease, isn't it? So now it's no longer how is your sugar? Is it fine? Fine, go home. No, we are actually going and seeing how's your kidney function? How is your ASCVD score? Yeah, and then what will all this do? Improve your quality of life. We don't want you to have amputations that are preventable. So it may not be the only thing, but it is. We are now looking at the patients holistically.
Okay. I see there's a question from Tom, which is similar to Dr. Moguchi's question, which we covered. Then there's a suggestion from Macduff Oguido that pre-entry medical exam forms should include a fasting blood sugar or a random blood sugar, in addition to the normal chest X-ray, VDRL, and immunization history.
Yeah, I think that's an excellent addition. Yeah, excellent. Agreed with you, Maxwell.
And I see there are people who are also asking for the presentations. After this, we will share the presentations with those who want them. Then there's a question here from Rosemary Mumbi. How would you differentiate type 1 and type 2 diabetes in the pediatric population in the peripheral facilities?
I'll talk about the ideal setup. And then we'll decide whether, you're in, periphery is periphery. So one we know, and there is a great assumption that when a patients with type 1 diabetes, and I'll do this in summary. So you have absolute deficiency of insulin, meaning that your pancreas is not producing any insulin, and so we have to supplement your insulin, okay? And so for these patients, if you want to see whether it's a type 1, your insulin, you'll do your insulin and your C-peptide, okay? And it will be nothing, okay? Because now that's produced in the pancreas. But then in patients with type 2 diabetes, we know it's more of relative insulin deficiency due to insulin resistance, and what causes insulin resistance is mostly adipose tissue, obesity, and everything else that comes with it, okay? So a good way to see, and even just when you look at a patient, patients who have type 1 diabetes are mostly lean, very wasted, okay? Patients who you're thinking have type 2 diabetes, who are pediatric, will mostly be obese, big, because of the whole pathology. But remember, you have to go ahead and still do your insulin and your C-peptide levels to check where are you lying. Will the treatment change? If a rule of thumb in the periphery, if a child comes less than 10 years and you're not able to do this further test, assume that it is type 1 diabetes and give them insulin. It will work both ways. Yeah.
Okay, thank you for that.
Thank you.
Yeah, thank you. For those people who are asking, we'll provide CPD points after the symposium. We will not have certificates of attendance, but there'll be CPD points. So thank you, Dr. Mithi, for that. That was very well put.
Yes, yes. Yeah.
One final question before we close, make it brief.
So we talk about exercise. Now there is a thinking about people who do hard work. That typical Kenyan woman in the rural setup who wakes up every day, goes to the shamba. Does that qualify as exercise? And when you're advising such a person, how do you go about that? They are lean, they are not obese, they work 8 to 5, carrying firewood, and they are diabetic.
So that's a good question. So right now we're moving into individualization of diabetes care, meaning we need any form of physical activity or exercise for 30 minutes. So if they're going to the shamba, doing a walk for 30 minutes, that's good, yeah. But then if you see that probably they're obese, you want to have a bit more caloric deficit, then you can tell them what you're doing is good because it's physical activity, it is not exercise. What you can do, you can put in another 15 minutes of a jog or a run or skipping, active aggressive exercise. Yeah, so any form of, but then people will tell you, I love teachers, but people will tell you, I stand for the whole day. That is not physical activity, isn't it? That is not exercise. Yeah, so that's how you need to see and go further and ask, so how long is the distance from home to where you're going? How fast do you walk? So you have to look at least the other moving for at least 30 minutes a day. Yeah. Thank you very much. I appreciate your time.
Okay, thank you. So for people online, we'll take a 5-minute break, then we'll come back with Dr. Kunga's presentation. And this will be on basal insulin initiation and titration. Thank you. So also for you people, 5 minute break, you can go get your tea. Then we come back for Dr. Olive's presentation. Okay. I forgot. You forgot for one of the guys. continue with the next session where we'll have 3 exciting presentations. And the first one will be on basal insulin initiation titration in the patient with type 2 diabetes. And this will be done by Dr. Oliver Kunga, who is a physician and who also has an MSc in epidemiology and also a fellow of ENSACOP. She's also a consultant physician and clinical epidemiologist at Mater Hospital. So welcome, Dr. Oliver.
Thank you, Dr. Jackie. You can hear me. Generally, I'm very loud. I'm just pretending to, because I have a microphone. So we'll get right into it. So I'm talking about basal insulin. For a long time when we were training, we would say insulin is this very mystical thing. You almost, every time a patient needs insulin, we had to call the physician. So I don't know whether it was designed that way on purpose for us to fear it when we were younger doctors, so that we can always call on the endocrinologists, physicians, diabetologists, or is it actually a hard topic? How many think insulin is, how many fear insulin? Okay. Now, aside from the physicians and endos, how many have started patients on insulin on their own? You're not specifically like either, you know, a physician or in the IMED field, but you started a patient on insulin. Yes, you can go back to your younger self, but it shows why you became an endo. All right. So by the end of this session, I hope I will have demystified it for most of us, including those who actually are endocrinologists, and maybe will learn a thing or two from the current protocols of how we need to initiate and intensify treatment when it comes to crossing over from your oral hypoglycemic agents to injectables, including insulin. So we'll just revisit the pathological basis of type 2 diabetes, goals of therapy in type 2 diabetes, treatment options, when do you start insulin, and specifically for purposes of this discussion, when do you initiate based on insulin? What are the current guidelines on initiation and intensification, which may be achieved through titration, and then barriers to insulin initiation and future advancements in type 2 diabetes management. So just a bit of background, and I think Dr. Carol has already touched on this. The current global prevalence at around 6%, that's more than 0.5 billion people. And by 2050, it is projected that around 1.3 billion people are actually going to be living with diabetes. That said, it's among the top 10 leading causes of death and disability. And I was chatting with someone earlier who was telling me actually things are changing as far as the NCD causation of death, even in our country. Meaning that the books we are reading, the data we had when we were training has heavily changed. You'll see that some of the what we thought were infectious diseases causing death are totally different. So a lot of scrutiny on our NCDs, top of which is diabetes and cancers. So our current local prevalence at around 3.3%, this is actually also a bit, I think it's a bit outdated data. I don't know whether KBSG has different figures. Dr. Rosie, current prevalence locally? You're working on it. Slightly higher. All right. So going on to 4%, projected to rise to about 4.5 by 2025. 2025 used to sound like it's so far off. That's just around 8-9 months out from now. So the highest prevalence still being seen highly in central Kenya. This graph basically representations of what we are talking about. Look at where we were 5 years ago in 2019, 2030 represented there in yellow, and 2045. So you can see that even if in Africa, we are just contributing to probably the smallest burden worldwide, still at an upward trend. So that is something scary. And like we were told by the initial speaker. We need to look at prevention more than the management and cure. So what are these risk factors in our setting that are disposing us to this steady increase in terms of the trend? So pathological basis of type 2 diabetes, and every time we see that diagram, it takes us back to physiology, some anatomy, so it's not something that is always welcome on a Saturday morning, but you'll bear with me for today. So type 2 diabetes, a consequence of a vicious cycle, many metabolic alterations taking place. A lot has been postulated for many years. Initially thought to be what was called a triumvirate model that was in the 80s. The three main things that people are looking at were what is the interaction between your pancreas, your liver, and the muscle? How is the flow in terms of a trigger of hyperglycemia, in terms of how it affects the three organs? Later, someone said, no, actually, there are 8 main mechanisms. They call it the, who remembers the name of the, when there were 8? Dr. Rosie? Ominous octet. Ominous octet then morphed, and now people are talking about the egregious 11. I'm not even sure we are talking about this now because there are so many mechanisms under study. So this basically is, to simplify it, what we think is the driver of type 2 diabetes. Type 2 diabetes. How do you get it? Of course, historically, we know it's an issue with the pancreatic beta cells in terms of the function and decreasing cell mass. And the final denominator of all this is a reduction in the insulin. So from that diagram, you can see we have an issue with your incretins, which are produced in your GI. This actually is what led to the development of your GLP-RA drugs. You have the alpha cell effects, alpha cell along with your beta cell, which form the endocrine component of your pancreas, and many other things listed there, including your colon, because if you've read through studies that have been going on showing the relationship between type 2 diabetes and dysbiosis, and how that then predisposes that particular cohort of patients to type 2 diabetes. So many metabolic alterations, but the bottom line is you end up with hyperglycemia. So evolving theories and treatment development targets, and also in terms of how you reverse from a pre-diabetic stage back to normalcy, or how you progress from diabetes, pre-diabetes to diabetes. So actually, this week I was looking at some studies that are showing possible remission. And the question is, can you have permanent remission just by having a sustained period of euglycemia? And that would be a big win in terms of when we talk about treatment intensification and very tight targets when it comes to patients who can sign, especially the younger patients. We've heard that now we are encouraged to screen 35-year-olds and over. Before, that was a bit higher. So if you are screened at, say, 35, 36, found to be type 2 diabetic, if we achieve tight control, of course, within the limits of what comorbidities you may have, is it possible to then be able to reverse it? If you catch someone at pre-diabetes, is it obvious that after a few years they'll progress to diabetes, or are we able to fully reverse it? Similar goes for gestational diabetes, which reverses once a patient is one. So these mechanisms, they are not just to say this is how somebody gets diabetes, but really they are to inform how we manage our patients. They are to encourage us to achieve that tight glycemic control, and also to be able to think, because as doctors, as physicians, it is our responsibility to continuously generate evidence that will better the lives of our patients and better the kind of interventions that we offer. So because inevitably these processes are progressive, many patients will eventually require insulin. So the question is, will you wait until a certain time, or is there room to start it the first day you see a client in your office? And we'll look at that. So this is basically in terms of the beta cell function, just a representation of what I was mentioning, that by the time you're being diagnosed, usually your function is at about half of normal. Then progressive decline, usually it was postulated around 6 to 12 years before you completely lose your beta cell function. That varies with very many things, including your genetics, lifestyle. So both host and environmental factors influence how quickly you lose that in terms of your beta cell mass and function. This I think is an interesting slide for those of us interested in diabetes and endocrinology, because a lot of research can come from this, including the remission I was talking about. Can you move from 50 back to 100, or can you delay this so that you stay at the midpoint? So something to think about. So as far as diagnostic criteria, this is a slide I'm sure we all know by heart. Generally, what we're using now, even at national level, is a cutoff of 6.5%. So if in your lab, in the facility where you practice, things are not being calibrated as such, then maybe you need to interrogate either the machine or the type of assays they are doing in terms of the current cutoffs. Pre-diabetic, anything about 5.7, and I think Dr. Carol had already mentioned that, and the normal, usually 5.6 and under. So what are the goals of therapy in type 2 diabetes? Of course, just like any chronic illness, you want to improve the quality of life of your patient by symptom control. Aside from that, you want to prevent acute complications, which often may lead to very debilitating states, including even death in cases of things like PKA and so on. And then the legacy effects that was mentioned earlier. What is that? Basically a delay in terms of the onset and progression of long-term complications. So we'll have a slide on that as well. For type 2 diabetes, always remember to look at hypertension. When you're intensifying treatment, are you on target as far as your blood pressure goes? Dyslipidemia, how is your HDL? Are you at the magic number 1.2, or are you falling below that? And what do you do about it? I think dyslipidemia is also something I'm very passionate about. Dr. Even tell you, I'm always hearing about it in the world rounds in terms of how we interpret our lipid profiles and the threshold for initiation of your statin, then which statin, it goes beyond just initiating, which one at what dose and what are your treatment targets when you're doing that. Then, of course, you look at the risk of thrombosis, both previous and current, and then emphasize on smoking cessation. So this, again, a pictorial, basically representation of the complications you expect, and the reason why the legacy effect is something that cannot be overemphasized. When you start your control early, when you're able to achieve your glycemic targets early, this is what you're trying to prevent, your micro and macrovascular complications. So as far as, you know, what will happen, your brain, the cardiovascular system, the kidneys, and we look at this in a bit more detail shortly. So the management of type 2 diabetes, of course, two major groups. You have your oral drugs and you have your injectables. When it comes to your injectables, you have what we all are more familiar with just because of access, cost, and availability, which is your insulins. And you also have your GLP-1 receptor agonists. So the GLP-1 receptor agonists, of course, becoming more and more popular in our markets, with more and more industry partners providing them within the country, becoming more affordable. Then you find that more and more patients are able to be put on this. Of course, again, in context, expensive or cheap is relative. So you have to understand where you practice and what your patients are able to afford, and interpret the guidelines in context. Just because the guideline says the most recommended, first recommended injectable is a GLP-1 receptor agonist, you have to ask yourself, can you depend upon the semaglutide or your liraglutide or the ones that are injected once weekly, which are even more expensive. So if the option available at that point is insulin, then you have to have that as your fallback. So you'll see that in 2018, the ADA-EASD consensus report had recommended that the preferred initial choice of injectables is your GLP-1 receptor agonist. But due to their risk of hypoglycemia and association with weight loss. However, basal insulin is recommended as the first option when you have a patient who has either very severe symptomatic hypoglycemia, or if the GLP-1 receptor agonists are not suitable for this patient. Suitability goes beyond the physiologic suitability of a patient, you have again to look at cost and access. So many patients will fall into that secondary category when you look at it in minute detail. So we can talk about that background of diabetes for days. It's no wonder diabetes is a whole degree on its own. But for purposes of this, I'll leave it as that and encourage us to go and refresh on what is the current data, the current epidemiology, what are the current trends and studies going on as far as diabetes. So when it comes to insulin therapy, as you said, it's one of the injectable therapies in diabetes. And you have to look at it in terms of what clinical situations will necessitate you to start insulin. And this is insulin in general, not just basal insulin. So a patient presents in DKA as the what is it called? The first symptom, so to speak, when they come to you for the first time, treatment naive, they've never been diagnosed with diabetes, but they presented to you in DKA. Of course, that's a situation where you need insulin, and of course, your insulin of choice at that point is not going to be based on insulin. You're going to have to use your short-acting insulins, the regular insulins to control fast. Before then, you have a long-term plan for this patient. So specific clinical conditions, including gestational diabetes, but in terms of the cold patients, so to speak, people who are not coming in acute complications, then you have to use the set thresholds. And these have already been agreed upon by the diabetes authorities, okay? So if your HbA1c is above 8 as the point of presentation, some literature will tell you above 8.5. Previously, a few years back, it was actually at 10. Now that target has come down just because of studies relating to treatment and in terms of achieving benefits in terms of prevention of acute and long-term complications. So when your A1C at diagnosis is around 8.5%, that's a patient you will consider for basal insulin at the point of diagnosis. If a patient has been on treatment, but persistently, even on those 3 oral anti-diabetic drugs, their A1C is sustained above 7, then that is a patient you will consider for transition to your insulin therapy, and so on. So patients with decompensation, as you said, in terms of acute complications, again, those are patients who will consider transitioning, or if their initial presentation is actually a DKA, then you treat them as type 1. So insulin replacement therapy compared with physiologic insulin secretion. What is the importance of this graph? Basically, in terms of your treatment targets, when you're thinking of putting a patient on insulin, what you want to do is mimic your endogenous insulin as much as you can. Yeah. Otherwise, there is pretty much no point. You're going to mark time at the same point if you're not trying to go back to default settings, as it were. So you can see the dotted blue line. That's in terms of what your background insulin replacement would be. So in purple, you can start with the purple. That's the natural insulin secretion, basically, throughout the day, how it behaves. This is in a normal person. So it's a steady state, you eat, the hyperglycemia, of course, induces an upsurge and then back down. Then at your next mealtime, that goes back up and then back down. So once you understand this, then things like the basal bolus regimen are going to make sense. When do you need to give your insulin around mealtime, and why do you need a steady state, which is provided by your basal insulin? In addition to that, when you provide that basal steady state, which is the best choice? Do you go for something that will cover you for under 24 hours, or do you go for something that covers you for more than 24 hours? If it covers you for more than 24 hours, do you go for the usual long-acting that will cover you up to 24 hours? Do you go for a 36-hour cover? Do you go for a 42-hour cover? And currently, there is a study on, for those of you who heard of the ICODEC, I think it's now going into phase 3 trials. Is it okay to also cover someone for a whole week? Would that be okay if you can just inject someone once and then for the next 7 days they are good? And what are the consequences of that? So the benefits of early insulin therapy initiation, again, just to emphasize, although we've already mentioned this briefly. So when you achieve good glycemic control sooner rather than later, you reduce your risk of development of complications, both acute and chronic. And when you do your intensive insulin therapy at diagnosis, of course, you allow your beta cells to rest and recover some lost function. This again brings that element of remission that I was talking about. Can you sustain it when you have glycemia for a time, or how does that work? So food for thought. Now, early glycemic control has been associated with reduced risk of microvascular and macrovascular complications. This was a study in the UK diabetes study group that actually did a long-term cohort study on where that legacy effect, whether it works or not. Then you also have some results there that I've quoted, the origin trial, again demonstrating that insulin slows down disease progression in type 2DM, and specifically they were looking at insulin glargine reducing progression by about 28% with a p-value of 0.006 for those who enjoy statistics. That one is statistically significant. Now, again, in terms of interpreting these results, you find so many trials. Always look at your statistical significance in context. Statistical significance does not always translate to clinical significance. So you have to look at it again with a balance. It may be relevant to the study, but on ground, it may not be applicable to your patient. A good example I always like to use is in terms of death. It may not be statistically significant, but clinically, if you have 3 dead patients in your clinic on one day, that is extremely, in fact, you'll be shut down. It's extremely significant. So it may not be statistically significant in terms of your p-value, but always look at it in context and in terms of clinical significance reference. Now, this one, again, just a graph representing your microvascular complications. They are looking at retinopathy, nephropathy, neuropathy, and microalbuminuria. And in terms of where your HbA1c will be, so the percentages on your x-axis, y-axis looking at relative risk. So this, again, a cohort study. So relative risk, basically looking at probability of clients or patients developing these microvascular complications over time. So you can see in purple, your retinopathy, the higher your A1C, the more. All of them basically in an upward trend until a plateau base. So every 1% HbA1c reduction will reduce your risk by that. This one I borrowed it somewhere online. I think it's a very good diagram just showing how you reduce deaths, myocardial infarction by up to 14%, microvascular complications by up to 37%, and amputations from your diabetic foot complications or deaths by 43%. So many types of insulin. We all know different classes. So we look at that shortly and how they differ in terms of onset, peak action, and duration. So you have your ultra rapid acting analogs, basically onset of action within very few minutes, under 15 minutes, peak of action at 1 to 3 hours, duration of action 3 to 5 hours. Now, this, I won't even dwell on this diagram. I always do something you can screenshot and hang in your office and always refer to it. What is the relevance of this? When you know the duration of action of these things, especially of the non-basal, when you're dosing them during your insulin intensification, the importance of knowing that your rapid acting analog is going to be in your system for at least 3 to 5 hours is so that you prevent the concept of stacking. There's something called the stacking phenomenon when you're canceling your patients, especially those who do self-titration, such that I won't casually decide I'll have my breakfast at 9. And because I have a meeting at 2, let me eat at 12 and then inject my mealtime insulin. Because what will that do? You know, stacking, like putting one thing on top of the other. You have dosed it at maybe 3 times a day because the client told you they have breakfast at 6, lunch at 1, and maybe dinner at 7, 8 p.m. So you know, but every time they're injecting their mealtime insulin, what they had in their system is is gone, yeah, in terms of the duration of action. So it is safe to inject. But when they have their so close together and unplanned, it means they add insulin on top of what they had, and that automatically predisposes them towards hypoglycemic episodes. So that is the significance of knowing the duration of action of especially that group of insulins. When it comes to your long-acting insulins, that is from the group where I've put the purple markings, your NPH, including your glargine, detamine, and the degludec group. The long duration of action of that is actually the context of our discussion today. When do you decide which basal insulin is good for your patient? Largely, they work similarly, but in terms of the client's lifestyle and comorbidities, you may decide on one over the other. In terms of how they are responding to the lower concentration insulin, for example, if someone is on glargine 100 vis-a-vis glargine 300, what are the differences? So why basal insulin? Again, back to that slide that showed us the endogenous insulin vis-a-vis the exogenous that we give in terms of treatment. Basically, your choice in terms of starting and in terms of the guidelines that we have now is because the basal insulin replicates your endogenous basal insulin. So as much as possible, you want to achieve a normal glycemic profile without an acceptable weight gain or hypoglycemia. That's how you base your choice of the basal insulin. As far as the choice, we've already said it's because it is what mimics your physiology as much as possible. And this slide is very similar to what we had shown before, basically showing you when you give your basal insulin, where the steady state level is, and then in terms of your short-acting insulin, when you give at mealtime, the rise and the fall. So properties of ideal basal insulin, a peakless profile. So you've seen on all the diagrams where we've shown basal insulin needs, it's a flat line, yes, it's a plateau. So that's what you need when it comes to basal insulin, not something that peaks and drops. You need something that is there constantly. And then a long duration of action. And this, of course, maybe not too long ago, even when I was training, both undergrad and my MMed, most of the patients were on premixed insulins. Actually, they were on the NPH combination. So this basal insulin, it's not too long ago that it has become more and more widely accepted, and people looking at guidelines and saying, yes, actually, this is what we should be on. So again, long duration of action, more than 24 hours, informing such knowledge, and then flexible dosing. Simple titration when you're intensifying your treatments, that is something that you're going to look at, because if you have a molecule that is giving you trouble in terms of intensification of treatment, if you work in a place where you cannot follow up your patient very closely, or obviously you're not able to admit a patient for 12 weeks just to look at their rise and fall in terms of, for example, postprandial glucose, then you need something that you can easily give instructions to a patient and you can communicate with them on phone through your diabetes educator or you, if it is a private clinic, and you're able to titrate accordingly every few days. And then we look at treat to target schedules and how that works. So how do you select your most suitable basal insulin? So these treat to target trials are what informed this. And the goal of these studies was basically not necessarily to compare the therapeutic efficacy of the insulins, but more so to look at the secondary effects, including collateral benefits and adverse events. Okay, so it's not just about tight control. Remember, we said what part of what you want to do is improve the quality of life of this patient. So you're not just adding days to their years. Okay, you want to add quality. That I'm not just persevering through this type 2 diabetes, but actually my treatment is making me feel better. I'm able to go to work. I'm able to play with my children. I'm able to do this and that. So looking at the secondary effects and also adverse events, which basically inform tolerability of the insulin regimens. So some of the things that have been found, and this is, I just quoted a few, when you compare your insulin detamine and insulin glargine, in terms of comparison with your NPH, So a reduced incidence of nocturnal hypoglycemia, something we fear because many, especially the aged patients, they tend to sleep into even death in the night because of nocturnal hypoglycemia. And this, I know, is one of the biggest barriers to insulin initiation for most doctors, fear of nocturnal hypoglycemia. So you see that this is less with your basal insulin. And things like insulin being associated with less weight gain compared to your glargine or MPH. Again, this being debatable with a lot of confounders, including host factors and environmental factors, the lifestyle of the patient, what is their diet like, what are their genes like, are they more predisposed to this weight gain, and also always interpreting context also. The ultra long-acting basal insulins like your Degludec and Glargine 300, showing that like the Degludec provides better, similar glycemic control to Glargine, but with lower rates of hypoglycemia. But the preliminary results from the ICODEC, it must have been released maybe towards the end of last year, when they're looking at the once weekly injection, because it's not yet in the market. The injection we have is the GLP-1 receptor agonist. But for the ICODEC, it's actually shown that the hypoglycemia risk it's more. So again, we'll see whether those results are shaky or whether it will influence it being released into the market and how that can be factored in terms of acceptability. Because I think many patients are asking for that once a week. You know, patients Google and they come and ask you, do you have this? They don't necessarily read the part where it says still under study. So if it will influence acceptability, then we are sure soon we'll get to know about that. So again, down there, yes, availability, and of course, something to heavily consider. Now, into the thick of it, current guidelines. I hope it's not too hazy. So I quoted this because it has recommendations from the ADA, the EASD, what the IDF says, and the American Association of Clinical Endocrinologists, AACE, something that a group that we quote from a lot as well. So when to start, you'll see that, when to start, we already looked at that in terms of the clinical situations, but as far as your A1C target, because you have to treat targets. And we'll see the purpose of having these targets tight and having your eye on them, and how do you do it? How do you progress from basal insulin only with your supporting OHS to intensifying with your short-acting insulins around mealtime? So your targets with basal insulin are 7% generally, but the AACE tightens that further to 6.5%. You may not always be able to achieve that high target depending on your comorbid and age of the patient, but that should be the goal. So when you look at the ADA EASD guideline, that's the one at the top, the initial dose, when you have decided this patient needs to be on insulin, how do you start it? How do you dose it? So this patient has been on at least 3 oral hypoglycemic agents, you're not achieving targets, or as you said, this client has come, their A1C at diagnosis is 8.5%. I think this is a candidate for basal insulin initiation, of course, alongside your metformin. How do I start? So generally, if I'm to summarize this for you, 10 international units, or if the A1C is 8% or thereabouts, then you start at 0.1 to 0.2 units per kg body weight per day. Remember, it's a once a day injection that you're likely to go for. All right. Now, if the A1C is way above that, way above 8%, going to around 10% at the time of diagnosis, you want to start it higher at around 0.3 units per kg per day. Okay, so depending on your A1C, you decide whether to start low or start high. If you're not very confident, always start low. Always safer to start low and then titrate up. Especially if this is a patient who you're fearing you may not have very tight oversight of, and they may slip easily into hypoglycemia. We look at the titration separately, but it is on this slide for those of you who want to go and have a deeper look at it after this. So aside from the guidelines, you also have manufacturer recommendations. And it's always good for us to encourage our patients to read the inserts that come with the medications. I usually feel like it helps a lot. Don't you say you're very passionate about medical education? I usually feel like those inserts, they really help us in our work in terms of education. You may not have time to sit down and take a patient through all the potential side effects and so on. Of course, they will not understand anything in the section of pharmacodynamics and pharmacokinetics, but you can use it to educate them at least on the side effects. So for insulin glargine 100, starting dose again, as we had said, around 10 units or 0.2 units per kg body weight daily. Similar to your detamir, and for the insulin glargine 300. So when you hear 100, 300, that's just in terms of the concentration per ml. So basically, for example, if you're using an injectable device, the delivery, what is delivered with that drop or that quantity of insulin is a bit higher with the 300 than with the 100. And actually, when you're intensifying treatment, you don't always have to switch to a different insulin. Sometimes you just switch within the same molecule from a lower concentration to a higher concentration. So that's basically what those concentrations are dealing with. And then for the degludec dose, that's one of the ultra long acting ones. Again, basic principle of 10 minutes once daily. Your conversion ratios, although today we are not talking about switching profiles, that's a whole topic on its own, but it's there for purposes of information when you want to switch from one insulin to another for various reasons. And one of those reasons is when you're intensifying treatments. And we look at those regimens shortly. So if you're switching from insulin glargine to a once daily NPH, how do you switch? Usually it would be, if you're using 10 units, you switch to 10, the ratio of 1:1 listed there, and so on. The titration, I want us to look at it separately. So this is a treat to target algorithm for basal insulin titration. So this one I borrowed from the Atlanta's algorithm. I think Dr. Maya is the custodian of that study, I believe. So when you start at 10 units, what is your goal as far as fasting sugar? And then how do you titrate? Now, I will heavily caution, again, do this at heavy discretion of you as the doctor seeing the patients. There are many things that will influence this, especially when you're looking at the postprandial glucose in terms of how heavy was the carbohydrate content in what they do. So don't just see one sugar and decide, we need to intensify. Sometimes you want to monitor over at least 2 to 3 days. Be sure that whatever advice was given by the nutritionist is being followed. What they're eating is something that you're aware of and they are free to disclose to you, so that then you make a conscious decision. Otherwise, there's a tendency to titrate up too fast, and then someone now decides that I'm going to be on a diabetic diet, and you end up with serious hypoglycemia and the complications of that. So again, when looking at this, make sure this is something that's a journey you're walking with the patient. So that then brings the discussion of, do you titrate as a provider, or do you agree for the patient to self-titrate at home? So that is debatable. And if you're going to self-titrate at home, how do you do it this way? It has to be documented. The advice that you give a patient in terms of, so when you see these figures, so these are milligrams per deciliter. Apologies, this is based on the picture that I took. 100 to 1, we all know how to convert this. I think even most of our glucometers come in milligram per deciliter, just divide it by 18. So 120 would be around 5, yeah, 5 millimoles per liter. I know that's what we use more commonly. So when they are looking at this, so when you tell them, when you see that your fasting sugar is steadily above 7, how do you go about it? So instructions for adjusting your basal insulin, so they have to commit to this. And the reason for this is because we have recently become a very litigious society. So our clients, you are relying on them to titrate with them on phone, and you've agreed that this is how we're going to go about it. Someone goes into nocturnal hypoglycemia, they die the following morning, the clients are in hospital with you. I think we see a lot of that in our hospital. We import almost, not that we practice bad medicine, disclaimer, but this is because people have become more and more aware of their rights as patients, and you're friends with the doctor until a complication happens to you or your family, and they will go very legal on you. The only way you will defend yourself is if you documented your outpatient instructions as such. So let the patient commit that indeed I have been started on basal insulin based on this and this condition, and my starting dose was this, and we've agreed that I'll be giving it at this time, and these are the stepwise instructions of how I should do it. So make sure you tell them if it's less than the target for more than a consecutive day, decrease by this. So this is just an example. You can customize it for where you work and in terms of the patient. So in, for example, point number 3, decrease your dose by 2 units if XYZ. You can leave it blank so that this is a paper that you can have many copies of in your office or where you practice, and you can easily detail it based on the current instructions you're giving the patient. Always date it, and if things change, remember to cross it and document the same. Now, as far as monitoring and targets, what we always say is you fix your fasting fast, FFF. When you're looking at your basal insulin at initiation, the number you have your eye on is the fasting sugar. Over time, of course, 3 months later, and usually the recommended standard for titration to targets as far as both your prandial and fasting glucose is 12 weeks. 12 weeks coincides with around the time when you want to do your repeat HbA1c. So keep your eye on those 3 when you're monitoring your sugar. So is my fasting on target? Yes or no? Is my prandial, and remember you're checking your fasting with the basal insulin. Your mealtime sugar, you're not checking them with your basal insulin. If your oral hypoglycemic agents are not able to control that together with your basal insulin, then you're going to move to your boluses at mealtime. That's where the short-acting insulin come in. Never check your mealtime insulins with the fasting. Otherwise, you'll end up with a concentric over-basalization, which is not recommended. So HbA1c in relation to your postprandial glucose and fasting blood sugar. This one is just for us to understand how do those contribute to your A1C range. So you can see your fasting sugar, your postprandial glucose, and how they contribute. So when you see an A1C of about 10%, where is the problem? And if you think about this critically, it influences what you start. The reason why you would start your basal insulin at an A1C that is high is because, as you said, you're checking your fasting sugar with the basal insulin, and you can see it's the highest contributor of that derangement. So most probably, you're easily able to achieve that with tight control. You're able to revert back to a target A1C on your basal insulin. So if at first you don't succeed, intensify. This again, a good rundown of how to intensify. We said you start with the basal insulin. If the A1C is still not controlled, now you consider combined injectable therapy. Combined injectable can be combined with your GLP-1 receptor agonist, the whole group, in terms of what you choose and suitable for the patient, or if by chance they are not able to afford it for 1 or 2 reasons, it's not suitable for them, then you move to that. Let me summarize this for you in English. So this is basically what that diagram says. There is regimen 1, 2, 3. And if you look at this, the one at the extreme, so that's to your left, that would be regimen 1, the middle regimen 2, and the last one, regimen 3. So if you're still not controlled, your first option is to move to a basal bolus regimen. So you do your basal insulin together with mealtime insulin. How you do the mealtime insulin will depend on how your postprandial glucose behaves. So if they just have one meal with high carbohydrate content, and that's when you have a serious derangement in your postprandial glucose, then that's where you will schedule it. So you can start with one. But we all know our Kenyan diet. We have high carbohydrates from morning to night. So most of the time, our patients will end up on basal bolus times 3. So basal and 3 boluses. That's how most of our patients will end up. The ones on kidogo, probably they're on 2. But most of the time, you hardly ever get patients who get 1 meal with high carbohydrate content. Usually it's more than 1 meal a day. So that's your basal bolus regimen. We've already talked about at how many units will you initiate your basal. When you're doing a basal bolus regimen, allow me to just go ahead. This is how you're going to dose it. The total dose usually is 50-50 is allowable, but strictly speaking, usually it's 45% basal insulin, 55% prandial insulin. And that is with a calculation of 0.6 units per kg per day at initialization. So what does that mean? If somebody is, for example, 80 kgs, how much would your total per day be? 80 times 0.6 gives us, quick math, 48. So your total dose of basal plus bolus will be 48. And then you divide that into 24. The 24 for your short acting is going to be divided into 3 for a typical Kenyan who's eating carbohydrates through, or your postprandial is always spiking, yeah? So you can do 8, so you can do a steady of 24 basal, and then 8 units of your short acting insulin at every meal time. Remember again what I've mentioned earlier, those meal times, remember, have your stacking effects at the back of your mind, and make sure you strictly cancel them on how, depending on which one you started them on, when to have their meals and when to administer that insulin. So monitor again your success with the targets that we talked about. Regimen 2 will be an additional GLP-1 receptor agonist, and if it still remains unmet or tolerated, then you can switch to regimen 3. For patients who your preferred injectable was the GLP-1 receptor agonist, remember we said there are patients who the initial injectable they go for the GLP-1 and they are controlled. So for those ones, you can now switch to regimen 1. Consider a basal. But for those ones who you started on basal, now you've done a GLP-1 receptor agonist, they are not responding, then you move to regimen 3, which is the one most of us are familiar with, which is your premixed insulins. So your premixed insulins again can vary from once a day to twice to even thrice a day. I will run through this in 3 minutes, I promise. The chair is looking at me very badly, but I think this was a heavy topic, Dr. Aman. I wish you gave me the numbers. Dr. She doesn't like numbers, I love numbers. So over-basalization, we talked about it. Over-basalization is when you're checking your mealtime insulin with your basal. It is not recommended. Your basal is supposed to have an effect on your fasting. If you have an issue with the mealtime insulin still, please intensify your treatment using your short-acting insulin or other relevant oral hypoglycemic agents. That is the summary of this slide. What is over-basalization? When you see that you've increased your basal insulin to higher than 0.5 units per kg per day, starts being weird. When that number hits 1, now it is a point of you cannot go further than that. And if you do go further than that, there are consequences to that. Now, as you said, what you consider in that case is consider more concentrated basal insulin preparation. You already mentioned that. Use your short-acting insulin and other glucose-lowering therapy. This slide we've gone through it more or less, how intensive glycemic control influences your development of microvascular complications. But is it that easy? No, it is not. And those are the numbers. Up to 25% of patients will be prescribed these things. So do not use it or don't come to refill their prescriptions. 62% have interrupted therapy and 18% will discontinue. Why? Because there are many barriers to compliance and initiation. Provider versus patient factors. We've already seen many of us fear that insulin. So already, even when you're starting it fearing. You're like, oh, I got a hypoglycemia, please stop it. Let us give you an SGLT2. It is oral, you'll be fine. So we as providers also fear it as much as the patients fear it. So as much as possible, do not allow your biases and fears to be the reason why a patient develops macrovascular complications 10, 20 years from now. Actually, that is a disservice to the patients. It is going against your Hippocratic oath because you're denying care because you refused to interact with the knowledge and be comfortable with doing the right thing. The right thing will always be the right. So as far as administration, we all know this, the options we have: pens, pumps, syringes. I will not go into that. Insulin pumps, again, becoming more and more popular. I'd encourage all of us to familiarize with the devices and see which affordable ones we can prescribe to our patients. It makes the glucose monitoring and even initiation of this therapy much easier. Complications with injection therapy, again, to be considered. I'm sure we are all familiar with that. Consider your drug interactions as well, because most of our patients on insulin therapy tend to be on multiple drugs. So how do those oral contraceptives affect that basal insulin? These patients don't have diuretics. What does that mean? And so on. So this, again, me being an epidemiologist, I enjoy studies. This is what is currently going on. Onwards, clinical trials, I think there's been at least 6 going on. I think the results of Onward 6 are the latest ones to have been published on the insulin hypothesis, which I mentioned. And then we have the oral insulin trials going on. So again, something that will be exciting. And I think next year we'll be hearing more and more about it. I think it will be good because one of the things you saw when I was putting the barriers is the fear of injections. So if somebody can take this insulin orally, what does that mean? Will your acidic environment in the stomach break it down? And I mean, we are just excited to see what this will bring about. Again, another exciting thing, heavily being studied, especially in China and Europe, your mesenchymal stem cell therapy. We were discussing this week with a colleague from China who is trying to see whether these things can be brought to Kenya for treatment of diabetes, pulmonary hypertension, anti-aging. Someone said we are old. Someone did see Dr. Amaya. So MST trials, what does that mean? Will we be able to achieve full remission? When you start at 50% and you're given the mesenchymal stem cell therapy, are you able to regain full pancreatic beta cell function? This one, just take a photo of because of time, and then you will go and interrogate it and try and answer the question based on what we discussed today. That's because we ran out of time. So thank you very much. I hope the key messages of the day are noted. I think I'm not sure we have time for questions, but I'll give it back to the chair. Thank you for listening.
Thank you. I think insulin is a topic you can do a whole 2 months daily what is it? Presentations and still not finish insulin. So you're right, it's a very heavy topic, but you have covered it well. So I think on the floor, is there any questions on the floor? Okay, as the people on the floor are thinking about their questions, maybe I can start with the questions that are online. We'll answer maybe 2 or 3 of them. Okay, the first question is from someone who asked, how can you replace insulin with oral hypoglycemics, and at what point do you do that?
That's a good question, and I think it's a very practical question, which we encounter in our practice a lot. If that a patient on insulin, you realize either their A1C has fallen ridiculously low, or they are having very many episodes of hypoglycemia, especially in the time. I think there is and I will ask Dr. Ngugi to comment on that as well. There is room to be forgiving in that case. If you feel like your insulin therapy is compromising the patient's treatment targets, then sometimes you can step back and observe, but under very tight oversight. But generally speaking, once you start your insulin therapy, as you've seen, there is a stepwise approach to it. If you started it at the point of diagnosis, the patient still living, their A1C is on target, they're minimal low, then really, why do you want to step back? Especially with the knowledge of what we call the legacy effects. When clearly stepping back or treatment based on what the patient prefers and so on is going to compromise then in terms of long-term complications, then I don't think you would step back without without proper reason. So for me, the only solid reason I see is if they are tending to get more hypoglycemia or PID, their quality of life because of clinical targets, not personal preference, is being affected. Then you can give a chance to your oral.
Okay. So the next question from this, it's a hypothetical question. You have a 45-year-old male with an RBS of 15 millimoles per liter. The next morning, the fasting blood sugar is 7.4 and the HbA1c is 5.8%. Will you start or will you not start on medication on this patient? That's the only information they give. So basically what to consider.
So this is a one-time point RBS, and you saw even in the context, this A1C is 5.8, looking at what? Pre-diabetes, meaning from time to time, this is someone who's, those metabolic alterations we talked about, it slowly predisposing them to being a type 2. So what you will do in that case is start them on the protocol of pre-diabetes condition, which includes lifestyle, but it's also room for starting things like your regular, the metformin, start low, and then observe. Just because of how our clients behave, it's physician dependent in terms of which route you will take. Personally, I usually start them on, or rather encourage them to be on metformin at least, as we observe and see. Sometimes they reverse, and you're able to come off that, but sometimes you actually end up going into full-blown anti-diabetes and starting treatment. So that's how I would look at it.
Okay. And I think a final one here. Does that mean to monitor using A1C will require monitoring the patient for 3 months before one can conclude that the sugars are controlled?
So with A1C, the 3 months with your fasting sugar, that's something they use the self-monitor plan, because that's nothing that you can do. But with your A1C, they need to the 12 weeks. They just basically based on the family conversation with HbA1c, whether it's you're having, at least we have transition.
Okay, just a comment about that. And I think what the speaker was, what the question was trying to allude to is a problem that we've been having in the practice is that we've relied so much on A1C only for monitoring of the patients. What you don't realize is if a patient is, say, pregnant and is prone to iron deficiency anemia, is a sickler, has chronic kidney disease, then you can't use just your A1C for monitoring of the patients. Another thing we're finding is that in as much as we're diagnosing more of diabetes, our patients are still presenting with complications. Hence the concept of self-monitoring of blood glucose. And now we've even introduced the concept of time in range. So even as you ask your patients to do the 3 monthly, or now in the public sector, 6 monthly or annually HbA1c, what they can afford, we actually advise to do some points of self-monitoring of blood glucose, because we've noticed when you have episodes of hypoglycemia or hyperglycemia, that fluctuation or variation in glucose is what is contributing to complications. So other than HbA1c, please ensure that they have some logs of their self-monitoring of blood glucose.
Okay, thank you, Dr. Ngugi. We'll now move to the next presentation, but before that, I'll request the people to stand up a bit. We've sat for long. I think last time Dr. Kunga said we should not sit for long. I remember. Yes. In fact, I remember she gave her presentation when people were standing up. I don't know if I should do the same thing. So let's all stand a bit. But the people at home, you should stand because you've probably been sitting or lying in bed for, I know we watch these things in bed with our blankets. Okay, so I want us to stretch. Make yourself as tall as you can. See, there are many tall people, Dr. Ngugi. Let's see how tall you can become. Tall, and then jump. You know, you can make yourself taller by jumping. Some people are still seated. Okay, let's make ourselves as tall as we can. Then we jump. The tallest jumper, I'm buying for them breakfast. Breakfast today. Somewhere in the world, it is still morning. Okay. Dr. Maya? Okay, have a seat. Okay. So we are going to go to our next presentation, and our next presentation is on diabetes nephropathy. So the first disclaimer, I'm not a nephrologist, so I will not be very technical. The whole idea is to give you an idea on patients with diabetes and comorbidities, what to look at and how to manage them. So the presentation will aim to give you more of a holistic approach that you can use for all complications. So one thing before I start this, there's a quote that my nephrologist friends always tell us, that nephrologists are not dialyzers. And by the time the nephrologist is dialyzing the patient, it's a sign of a failure. And more often, the failure is on our part, the people who are managing the patient before they reach there. So, I want to start with, I want to put up a case, and if we have time by the end of the presentation, we can maybe go back to the case, but I just want you to have this gentleman at the back of your mind so that even as we are going through the presentation, you can see where this gentleman fits. So a 45-year-old gentleman who presents with fatigue, headache, insomnia. As you get further history, it turns that 2 years ago, this gentleman was told that he had pre-diabetes, and because he was scared of diabetes, he was very motivated to do the lifestyle modifications. So he started exercising, he adjusted his nutrition, and he ended up losing up to 10% of his weight. And with losing 10% of his weight, his sugars normalized. Then, as so often happened, the motivation died with time. He stopped seeing his physician. He got a promotion at work. He became more busy. He did not have time to exercise, and he was being paid better, so he was eating more. So his weight came back. And then also he was traveling more, and with travel, the nutritional advice that he had been given before now became a problem, because he would go to countries where he would not recognize the food, or he would not be able to get the things that he knew. So even the eating became a problem. So this gentleman, the reason why he came to see you is because he noticed that over time his vision is getting worse. And now when you probed further is when you discover that he had fatigue, headache, insomnia, and the osmotic symptoms of polyuria. So when you examine this gentleman, the things that stand out is he has a weight of 112 kgs and a BMI of 30. His waist circumference was 120 centimeters. He had a normal cardiac examination, and he had a foot at risk. You did a lot of investigations as we physicians like doing, but I just listed the ones that stood out. At that point, his random blood sugar was 17 millimoles per liter. His HbA1c was 9%. He had a HB of 12, which is important when you're interpreting your HbA1c, as Dr. Ngugi said. And his eGFR at that point was more than 90, with a normal urea and creatinine. And he had a microalbuminuria of 50 milligrams per deciliter, and his LDL cholesterol was 6 millimoles per liter. So let's keep this gentleman at the back of our mind. Then at the end of the presentation, we can come back to this gentleman and we'll see what we'll do for this gentleman. So just as an introduction, the scope of the lecture was a bit wide, and it was to discuss nephropathy and other diabetic complications. But just like insulin, diabetic complications is something that you can take a whole year to discuss, and we didn't have time. So I decided I will concentrate more. Sorry, can we remove the top line? I'll concentrate more on nephropathy, and then later on with other presentations, we can look at the other one. But just as an introduction to complications, this is just a basic diagram to give you an idea of the main complications we deal with. When I remember when I was in school, and I see there's someone here from infectious disease. We used to have a saying that TB affects everything but the hair and the nails. I think that is still there. But now diabetes is one of those things that affects everything, including the hair and the nails. So as much as we mentioned this one, just know every single organ in the body can be affected by uncontrolled diabetes. But the main ones that we talk about are in the brain, you're worried about getting strokes, you're worried about cerebrovascular diseases, you're worried about dementia. Then in the eyes, you worried about diabetic retinopathy, you can get cataracts and you can get glaucoma. In the teeth, periodontal disease, and very interesting, there's a study that Colgate did with some, I forget the name of the PI, and they found that just brushing your teeth every day and improving your dental hygiene would actually reduce your HbA1c by 1%, even without changing anything else in your treatment. So let's brush our teeth. Then the other one, cardiovascular disease, which we all know, you can get MI, you can get angina, you can get heart failure. You have peripheral vascular diseases, you have diabetic nephropathy, which is what I'll spend more time on. You have neuropathy, and of course, diabetic foot, which is last but not least. So these are just some of the major ones, but remember, diabetes can affect every organ of the body. So, my screen is not moving. Okay. So what's next for this gentleman? So what are the things we need to consider? So when it comes to diabetes kidney disease, first, diabetes kidney disease, I think, let me start with this slide first. It has very many names and it goes by many names. And you can either call it diabetes kidney disease or DKD, chronic kidney disease of diabetes, or diabetes nephropathy. All this can apply to diabetes kidney disease. And definition of diabetes kidney disease, sorry. Okay, this is the outline of my presentation. This is the other names for diabetes kidney disease. So before we go to the definitions, let's go to the statistics. Again, for Kenya, our statistics, I was not able to find a lot of published statistics on that. Most of the statistics I was finding was mainly for CKD. But for the world, you find that even worldwide, 59 to 66% of deaths in patients with type 1 diabetes and nephropathy is due to end-stage kidney disease. So it is a major cause of complications. It is a major cause of complications. And you see, it happens both in the elderly population and in the younger population. Now, in Africa and in Kenya, the statistics are found. There's a paper that was written by Peter Maritim and Dr. Twahir, and it was looking at the prevalence of diabetic kidney disease in Kenya. And they found that this is estimated to be at around 4%. But remember also with that, not all of our patients have been diagnosed and we don't have all our patients in care. So it's quite possible that this number could be higher. And most of these patients, when they checked at the prevalence, they found that the main risk factors was actually age and HIV. With time, diabetes and hypertension are coming up as the major risk factors in Kenya, but initially it was mainly age and HIV. And then they also mentioned that unpublished data from the Kenyan Renal Registry indicates that hypertension and diabetes are now becoming more as the cause of patients who are having kidney replacement therapy. And remember, not all of our patients who have end-stage renal disease end up having renal replacement therapy. So again, for our renal physicians, this is an area that you can look into because I think it is a right area for studies. So our definition for diabetes nephropathy, it is a clinical syndrome that is characterized by persistent albuminuria. It has to be persistent and it has to be confirmed on at least 2 occasions, 3 to 6 months apart. So one may not be enough for you to diagnose this patient as having diabetes kidney disease. And there also has to be a progressive decline in the glomerular filtration rate, and this patient should also have elevated arterial blood pressure. So this slide is the pathophysiology. The pathophysiology is very complex, and again, most of it is not well known. And there are 2 pathways. There's the metabolic pathway and the hemodynamic pathway. So if you look to your right for the people here, the right part, you'll see the metabolic pathway, and you can see that in this patient, at the middle here, you can see the major thing are the cytokines. And you can see that glucose, in this case, you're talking about poor glucose control and other factors that they have not yet determined will lead to the advanced glycation end products. And this leads to extracellular matrix cross-linking. And then this, at the end of the day, will lead to extracellular matrix accumulation and proteinuria. If you look at the hemodynamic part of it, you'll see flow and pressure. Remember, these patients also have hypertension. And with this, you get increased vascular permeability. And then this also leads to the increased extracellular matrix and extracellular matrix accumulation and proteinuria. So there are very many pathways that happen. And at the end of the day, regardless of the pathway, you have the end being the extracellular matrix accumulation and proteinuria. So we know that patients who have end-stage renal disease, or even patients who have diabetes, even without renal disease, will also have hypertension, a majority of them. And hypertension, even not well controlled, can also have deleterious effects on the microvasculature. Then we know diabetes and obesity are also well related, and obesity on its own can lead to hypertension. And this is maybe because with obesity, you have increased reabsorption of sodium through the nephrons. You have activation of the sympathetic nervous system and the RAS system, and you have physical compression of the kidneys. So this on their own will also lead to hypertension that will lead to microvascular that will have an effect on the microvasculature of the kidney. So when you come to the categories of CKD, so this slide obviously just gives you the categories of CKD from stage 1 to stage 5, and this they cross-link it with albuminuria, because remember, some of these patients will have albuminuria and not necessarily have CKD. So when you get a patient, it's also important for you to get the rate of decline. And you can see the rate of decline in GFR is different whether you have a patient with type 1 diabetes and a patient with type 2 diabetes. And if you see, if you have a patient with type 1 diabetes and they have no albuminuria, so you'll see the rate of decline in the eGFR is 1.2 to 3.6 per year. This is per year. And for type 2, it's a bit slower, 0.96. If you have microalbuminuria, for type 1 diabetes, you see that rate of decline does not change much. It's still high. But now for type 2 diabetes patients, you see the rate of decline now becomes much more. And when you have a patient who has overt nephropathy and who has frank microalbuminuria, then you'll see the rate of decline now is much more. And if you look at that rate of decline, you have an eGFR of more than 90. And usually by the time a patient is requiring dialysis, the eGFR may be 30 or below. So if you look at a rate of decline of even just to use one per year, you can see that you have quite a lot of time for you to initiate changes that will prevent this patient from ending up in end-stage renal disease or ending up on dialysis. So we actually have time to sort out this patient. So what is the prognosis of proteinuria? What is the importance of proteinuria? Why is it a problem? You can see a patient with proteinuria has a 40-fold higher risk of morbidity and mortality than a patient who does not have proteinuria. And that is significant. And if you look at that, you'll see that if you look at cardiovascular morbidity and mortality, this will increase more in patients with diabetes and especially in patients with proteinuria. So this proteinuria doesn't just affect the kidneys, but it is an indicator that there are more things happening in other important organs in the body, and it is important to think about this. And you can see increased risk of coronary and peripheral vascular disease and death is actually higher in patients who have diabetes and even higher in those who have diabetes and proteinuria. And even if you look at patients who do not have diabetes and have proteinuria, you know, because of the different glomerulonephropathies, patients can present with proteinuria without diabetes. Even with them, the risk of cardiovascular disease, morbidity, and mortality is higher than in patients who do not have proteinuria. So it actually impacts on the prognosis of your patient. So let's come to management of this patient. So management is holistic. Remember, as much as your patient has proteinuria, you're not just looking at the kidneys, because remember, this is impacting on the whole body, and you have to look at the patient as a whole. So if we start from, if you look at this from 12 o'clock where you have smoking cessation, then we will move clockwise. If a patient is smoking, it is very important to stop the patient to reduce smoking. And most patients may not be able to stop smoking at once. And this is where things like the nicotine patch and the nicotine gums come in. And actually, there is a dosage of nicotine patch and gum that the patient uses in relation to how much packs of cigarettes they are smoking per day. And a lot of times you find if you use the right doses, you're better able to get this patient off cigarettes than just telling them to use a patch or to use the gum. Then blood pressure control is very important because, you know, blood pressure is an independent marker for, again, kidney disease, for the cardiovascular disease and all this. So blood pressure control is important. And then using RAS blockade, and we'll talk about this more a bit later. And this is whether or not the patient has hypertension. And then controlling your blood sugars so that you find if a patient who has diabetes and who has renal disease and is on metformin and is on an SGLT2, now these are patients who may think of adding a GLP-1 receptor agonist to their treatment. If a patient has atherosclerotic heart disease, you'll add an antiplatelet to their treatment. Lipid management by whatever molecule that you use to manage the lipids depending on your patient category. Again, weight control. There's also a role for mineralocorticoid agonists, the non-steroidal one, in the patients who have refractory hypertension. Then there's glycemic control with the different drugs. There's glycemic targets, there's exercise, there's nutrition. So I'll try and at least mention a bit further all of this, but this is a summary of the things you need to manage. So when you get your patient, as much as all our talks, we talk about drugs, let's not forget lifestyle. Lifestyle is very important. One, lifestyle modification for patients who are not following the right advice. If you institute lifestyle modification, you're able to prevent patients from getting to a point of complications. You're able to control their blood pressure, blood sugar, whatever you do, whether you're in rheumatology, you're in diabetes, whether you're in mental health, lifestyle modification is important all across the board. So even as we talk about our molecules, let's not forget lifestyle modification. And when we talk about lifestyle, we are talking about a healthy diet and healthy nutrition. We are talking about physical activity. We are talking about smoking cessation. We are talking about weight management. Then now we're at the second row, we are looking at the drug therapy. So in a patient who has diabetes and who already has kidney issues, these are patients that now, when you're looking at your drugs, you want to use the SGLT2 inhibitors much earlier because they have proven benefits in patients who have both proteinuria and other forms of kidney disease. You can use metformin, and this is only if your eGFR is more than 30. If your eGFR is less than 30, then you need to stop metformin. And this is why you need to evaluate your patients regularly and do your eGFR regularly, depending on your patient, so you don't miss having a patient who is having a low GFR and this patient is still on metformin. Then if a patient who has diabetes also has hypertension, among the drugs you will consider as one of your initial drugs will be a RAS inhibitor, which is either an ACE inhibitor or an ARB. And this you give it at the maximum tolerated doses to achieve the blood pressure that you want. And then statin, you can give either a moderate or high intensity statin depending on the risk of your patient. Remember, there are those many risk calculators that you can use to calculate the risk of your patient, and then your statin dose will depend on the risk profile of your patient. And with all this, again, you're doing regular assessment of your glycemia, you're checking your albuminuria every 3 months if you can, every 6 months if you can do 3 months, you're making sure your BPs are well controlled, and you're checking your lipids. If all this doesn't work, then we move to the next tier. And in this one, you see GLP-1 receptor agonists can be added onto your treatment. They are not used as much in our country, again, mainly because of costs and availability. But if your patient is able to afford them, these are things you'll consider high up in your treatment regime. Then the MRA, the non-steroidal mineralocorticoid receptor agonist. If your ACR is more than 30 and you have a normal potassium, we'll go more into that a bit later. Then you'll use your CCBs to achieve good blood pressure control. Cardiac, if the patient is at high risk and needs an antiplatelet agent, you put them on that. Then if you are giving your patient high intensity statins and you still have not achieved your target control, then you'll think of drugs like ezetimibe, the PCSK9 inhibitors, and all those other drugs. Okay, so remember, you need to evaluate your patient continuously. Sometimes it may not be easy, maybe because patients do not come to clinic as frequently as you want, or they come but they are not able to afford. But where possible, make sure you monitor your patient constantly, check for the ACR. Blood pressure is something they can even check at home, blood sugar, so that you make sure everything is controlled well. So when you come to glycemic control and you're looking at the drugs that you want to select, again, I think we'll start from up, where you have this orange or peach, the outer circle. For people who color is an issue, we start with the outer circle. The outer circle is the less suitable medications for this patient. The zolidindiones are not very suitable because one of the things that they cause is fluid retention. And a patient who has CKD will probably already have fluid retention issues. So those are drugs that you may want to avoid in this patient. Then you have sulfonylureas. Again, sometimes with sulfonylureas, you get higher incidences of hypoglycemia. attack, hypoglycemic attacks. So those are drugs that you may want to consider, either dosing low or even reducing them in patients who have CKD. And then now if you go to the most suitable medication, you can see my pointer. Yeah, you have the GLP-1 receptor agonist, you have insulin, you have the SGLT2, because those are drugs that are good. They have actually been proven to have a good effect on the kidneys, and in some cases may even reverse the proteinuria or retard the progression of the CKD. So what are your key objectives for management of this patient? So your key objectives, one, you want to improve your the diabetes-related knowledge, beliefs, and skills of this patient. Because at the end of the day, the patient is the one who spends most time with themselves. So you want them to be able to carry out most of your measures, even when they are not with you. And they can only do that if they are aware why they are doing what they are doing. Otherwise, it will just become daktari alisema. So they only do the things when they know, like you have patients who, when they know they're coming to see the doctor, the week before that, they start eating well, they start drinking more water, so that by the time they come to see you, their blood sugars look better. If they're fluid overloaded, they stop drinking as much fluid as they were drinking, so that their fluid levels reduce, so that you think they are doing well and they're doing these things for you. So you need to educate them so that they understand that what they're doing is for themselves and not for you. Then you need to motivate these patients. And you find a lot of times patients who have chronic diseases also have some element of depression, because they get tired, they keep on doing these things that they may not be seeing the impact, or they get tired of taking medication, they get tired of going to parties and everyone is drinking and they can't drink, or everyone is having cake and they can't have the cake. So you have to keep motivating your patients so that they don't lose hope. Then always stress the healthy lifestyle. Always talk about lifestyle modification. Improve your vascular risk factors. This is by improving your blood pressure, improving your blood sugar control. Sorry. You want to reduce risks to prevent diabetes-related complications. And again, like I said, emotional and mental well-being of this patient, and check on their quality of life. So this is again a summary of the same thing. So if your patient comes, if you look there at number 1, number 2, the patient will come, they will register, go through triage and all those things and come to you. Always do a risk assessment for your patient. Whether you're seeing your patient for the first time or you're seeing your patient for the 100th time, always do a risk assessment for that patient, because patients change and risks change. And then if the patient has optimal control, then we are going clockwise now. So that's a happy face there, the smiley face. If you see your patient has optimal control and is empowered, encourage this patient. When you see this patient, you do your risk stratification, and you see this patient is having issues, then you go to coordinated care. And by coordinated care, Dr. Maya talked about it, Dr. Akunga talked about it, Dr. Miki talked about it. You can't do it alone. You work with the nutritionist, you work with the counselor, you work with the podiatrist, you work with the nurse, you work with the educator. All these people, this is what you talk about coordinated care. Because more often than not, you'll find, if you have a team working with you, you find there are patients who, before they come to your room, the nurse will tell you, doc, this patient has this problem, or doc, I've seen this patient is not taking their drugs. Because the patients may be scared of telling you something because they don't want to disappoint you, and I put that in quotes, but they may be freer with the counselor and with the nurses and with all that. So you need to have a team so that whatever you will not pick, those other people can also pick, so that you don't miss anything in your patient care. Then again, always review, number 4 and 5, always review, check your risk factors, check, have you controlled your risk factors? How are things doing well? So if you look on this is the left side. The left side for the people in the room and the right side for the people at home. You'll see if you do not have coordinated care and you have uncoordinated care, you'll have a poorly informed patient, and poorly informed patients more often than not will have suboptimal control. So always remember, if nothing else you take away from this, always have coordinated care and think of the patient as a whole. So when you have patients with diabetes, kidney disease, and patients with diabetes, kidney disease, and again, multi-competent, integrated, and team-based care, that cannot be overemphasized. So when you look at this care, you have the physician kind of care and the non-physician care. So if we go to the left side of the screen or right side, depending on where you are, the non-physician care, this is the special education and counseling. We have the diabetes educators counseling, and we have the nurse educators. And you know, we may not always be in facilities that have nurse educators. So there are courses that you can do, whether you're a doctor, you're a podiatrist, whether whoever you are, there are courses that you can do to be a nurse educator, just to know what you're supposed to tell your patients. These courses are offered by KDSG. You get in touch with us and we can help you with those courses. So when you're talking about this, what do you talk about? You talk about the nutrition. We're always talking about weight reduction, always check the food of the patient, and stress management. And then ongoing psychosocial support, because these patients have, with chronic diseases, you can have peers. There are people who have group counseling, which works. You have community workers who can go home and see what the problems that people are having at home. Then you have families and friends. Then expert patients are those patients who have gone through it, and sometimes you'll find the patient will listen better to someone like them rather than listen to you, because what do you know? You don't have this problem. But if someone who has the same problems as them tells them the same information, then they receive that information better. So when you look at the non-physician care, you have regular structured assessment. So even with these nurse educators, when the patient comes to your facility, they always check for the risk factors, the complications. They go over the lifestyle modifications of the patient. They check the nutrition, the exercise, use of tobacco, alcohol, whether the patient is self-monitoring. If not, why? Are they using the devices nicely? Do they know how to use a glucometer? Do they know how to store it? And all that, and drug adherence. And then when you come to the other side, you have the physician care. And the physician care is the multidisciplinary care. So this is individualized goal. Remember, the HbA1c goal will not be the same for all your patients. It will depend on what kind of patient you have, what comorbidities, what kind of motivation they have. You monitor the clinical progress of the patient and assess risks and benefits. And you'll find in most well-organized diabetes centers where the patient will go through all this before they reach the physician, most of the time they'll spend the least time with the physician, because all these other people have done half the work for you. Okay, so just to mention a few of the treatment modalities that now we had mentioned before, we'll talk about the RAS inhibitors, that is the ACE inhibitors, the ARBs, the mineral corticoid receptor agonists, the SGLT2 inhibitors, the GLP-1, and all this we look again at glycemic control and lifestyle modification. So the ARBs, which are the angiotensin receptor blockers or the ACE inhibitors, they reduce proteinuria, and they do this by lowering the interglomerular pressure, so by reducing hyperfiltration. And it has been found that this is crucial for the preservation of the glomerular structure and the function of the glomerulus. So again, when you're initiating the ACE inhibitors, for those who want to start the patient on an ACE inhibitor, before you start it, if you are able to, monitor the serum creatinine and the potassium. And once you start the ACE inhibitors, you'll check this again. If you want to up-titrate the dose of your ACE inhibitor because you're not achieving your targets, you should also check your serum creatinine and potassium. If the patient has normal potassium, normocalemia, and you have a less than 30% increase in the creatinine, then this is a patient that you can, if you had already started them on an ACE inhibitor, you can safely increase the dose of the ACE inhibitor. If a patient has hyperkalemia, then you need to review the concurrent drugs the patient is using, because apart from the ACE inhibitors, there are other drugs that can lead to the hyperkalemia. You check the diet of the patient, because remember also potassium comes from the diet. Then you can consider ways of managing the potassium, because before you stop the ACE inhibitor, you may want to see if you can manage the hyperkalemia because of the other benefits the ACE inhibitor has to the patient. So if you check the patient and you see the creatinine is going up, again, if the creatinine is going up, then you're thinking this is AKI. Then review the causes, check, are there other things? Has the patient had an infection? Is the patient taking something? The patient on a drug that they're using that could be causing this? Remember, a lot of our patients with chronic diseases are also having pain, and a lot of them take a lot of non-steroidal anti-inflammatory drugs, which can actually lead to kidney issues. So always review drugs, not only the ones written for the patient, but also drugs that they could be taking on the side. Correct any volume depletion the patient may be having, then reassess the medications. And then if you've ruled out everything else, you should consider now other causes like renal artery stenosis. If you've done all this and you see that you still have hyperkalemia, then these are patients you should consider reducing the dose of ACE inhibitors. And if you're still not achieving what you want in terms of these complications, then these are patients who consider stopping the ACE inhibitors. So what are the KDIGO guidelines for ACE inhibitors? The KDIGO guidelines say that a patient who has proteinuria and diabetes and normal blood pressure, you should still consider using an ACE inhibitor or an ARB. You should monitor changes in blood pressure, check the serum creatinine, check the serum potassium within the first 2 to 4 weeks of initiation or increasing the dose of an ACE inhibitor. You should continue them unless your serum creatinine rises by more than 30% within 4 weeks. This is following initiation of treatment or an increase in the dose. Hyperkalemia is associated with ACE inhibitors, can be managed by the other measures we have talked about, and you should consider either decreasing the dose and only stop if these mitigating measures are not working. Okay. So ACE inhibitors, again, when you're using it with women, remember, also with women, when you're doing risk stratification, always ask about pregnancy and last monthly period, especially with women of childbearing age, because some of the drugs we are using for managing their blood sugar or their blood pressure or their cholesterol are not for use in pregnancy. So always remember to ask for that. So advise women on contraception if they are women of childbearing age. And if they decide they were planning to conceive, then these are patients you should consider stopping the ACE inhibitors. And never combine an ACE and an ARB. There's been no proven benefit with combining the two, and this can also be potentially harmful. If you get a patient who you're using them and you have symptomatic hypotension, then you're not able to manage that, this again patients who you'll want to consider stopping the ACE inhibitors. Then I think I'll just talk about the SGLT2s because of time, and then I'll stop at that one. The SGLT2 inhibitors are also important. And these are one of the many drugs that were initially developed for diabetes, but more and more you find they're being used for other things apart from diabetes. They're being used by the cardiologists and the nephrologists, even more than as patients, us who manage diabetes. And basically the SGLT2 inhibitors work by inhibiting reabsorption of blood sugar in the SGLT2 channels. If you look at the nephron, the first part there, that is where you have the SGLT2 itself, and what they do is reabsorb glucose. So when you inhibit them, you inhibit the absorption of glucose, so that at the end of the day, you have increased glucose excretion, and thereby you end up controlling your sugar. That is what initially it was designed for. But with time, they found that apart from reducing the sugars, these drugs actually had an effect, a positive effect in heart failure, and had a positive effect in renal disease. So what are the KDIGO guidelines on use of SGLT2 inhibitors? And you find that if you have a patient who has diabetes and has CKD, then you can actually you should add an SGLT2 inhibitor to their current treatment regimen if they are not already on them. And you find the choice of SGLT2s should be prioritized to agents that have documented kidney and cardiovascular benefits. And so far, when you look at the literature, especially for the kidney, you have empagliflozin and dapagliflozin are the ones that have enough studies to show their benefits. And of importance is that if you have a patient who is using an SGLT2 inhibitor and they're doing prolonged fasting, they're going for surgery, or they have a critical illness, these are patients where you want to withdraw the SGLT2 inhibitors for a period of time, because they are at greater risk for ketosis. Again, when you use an SGLT2 inhibitor, one of the things is that it does is increase diuresis. So if your patient is already on a diuretic, then you want to consider reducing the dose of your diuretic to prevent hyperdiuresing your patient. And you should also tell your patients if it's a patient who can take more fluid, to take more fluid and to monitor their pressures, because again, this can lead to hypotension. When you first give an SGLT2 inhibitor, you may get an initial drop in the eGFR. So you should not stop just because the GFR has dropped initially, but you should monitor this patient because this eGFR goes up with time. If you have a patient who is on an SGLT2 inhibitor and the GFR drops to below 20 millimeters per minute, then these are patients who you can actually continue the SGLT2 inhibitor. But if you have a patient with a eGFR less than 20, then most of the time you do not start an SGLT2 on this patient. There are some you refer to a nephrologist, and some would consider starting, but this is not the general rule of practice. Okay. So I think to finish off with the SGLT2s, just what I'm saying, just assess your patient. Do they have an eGFR of more than 20? If they do, then you can start it. If they don't, then that is a patient you want to be very cautious. Check what is their ACR. Do they have an ACR of more than 200 milligrams per millimole, more than 20 milligrams per millimole? Do they have heart failure? Because these are patients who you'd have a very now high incidence, high of starting the SGLT2s. Check for the potential contraindications. Are these patients who get frequent genital infections? Are they patients who are prone to diabetes ketoacidosis? Do they have foot ulcers? Do they have immunosuppression? Doesn't mean that you will not initiate for all of them. It just means that even if you initiate, you will monitor this patient more closely than the other patients. Okay? And then you check, you give, like we said, SGLT2 with proven benefits, and the ones we have here is dapagliflozin and empagliflozin. Educate your patient on the sick day protocols. That is on, like we said, prolonged fasting, patients who are sick, who you'd want to eliminate the dose for a few days. Perioperative care, you'd want to eliminate the dose for a few days. Teach the patient about food care, and then again, you will follow up the patients. Okay. So I think I will stop there. Maybe just one thing to mention for glycemic control, mention about your target. When we were talking, Dr. Kunga mentioned, here in Kenya, our target HbA1c is 6.5% to say that a patient has good control. But again, this depends on the comorbidities of the patient. So you find a patient who has CKD and many macrovascular complications, reduced life expectancy, hypoglycemia awareness may not be so well. These are patients who you don't want to be at 6.5. You're comfortable being below 8%. So depending on your patient's check and assess your patient, so you decide on which HbA1c target you want to achieve. So I think I will stop from there. I will stop there, and I will introduce Dr. Roslyn to come and finish up. Then I think we'll answer our questions together, because I think some of those questions may even be answered by Dr. Roslyn. So Dr. Roslyn Gugi, I think we all know her. She's current chair lady of KAP Nairobi branch. She's a lecturer, she's an endocrinologist, she's many things, and she's nice. So welcome.
Thank you, Dr. Jackie. You know, the problem of being the last piece of the day, everyone has really hyped you up. So I better live up to the expectations. But if you keep hearing me say, refer to what Dr. Miki says, refer to what Dr. Maya said, refer to what Dr. Kunga said, it's probably because it's repetition. And we don't want to belabor some points, but I think it was Dr. Kunga who said she was given such a wide topic to cover in a short period. Now imagine my Herculean task of summarizing management of diabetes in 40 minutes. I'll take an hour. Thanks, Amaya, in advance, and the chair. Right, so it's talk about the updates in the management of diabetes, and then I'll briefly talk about what our plans are in terms of guidelines in diabetes. So we all know about diabetes. Again, yes, so we know about the classification of diabetes, and we are not going to belabor the point about you need to know how to classify diabetes so that you can be able to manage accordingly in terms of management. Right, and then Dr. Miki had taken us through what's the criteria for diagnosing diabetes, and you required a fasting plasma glucose of more than 7, a 2-hour postprandial glucose after doing the oral glucose tolerance test of more than 11.1. You always have to have targets so that you understand how you're going to manage your patients. An A1C of more than 6.5%, and then anyone who's having osmotic symptoms and they have a random sugar of more than 11.1, then you have options. Yes, diabetologists are nice to think about what are the problems you could be experiencing when you're trying to make a diagnosis for a patient. Your classic symptoms before it used to be polyuria, polydipsia, polyphagia, and weight loss, and now we no longer say polyphagia is a classic symptom because it was actually locking people out. So the predominant symptoms predominantly because of hyperglycemia, urea, and the polydipsia. Then we need to think about screening. Dr. Miki talked about, instead of focusing so much on just management, how about we try and prevent? And that means we need to start screening in the population. And so who are these high-risk populations? She even talked about it. Screening of subjects with pre-diabetes, because we can actually reverse this instead of them progressing. Screening of women with gestational diabetes, and we are actually privileged to have a gynecologist with us. If there are any questions, he can also answer. I like they have co-opted him without him realizing. And then there's universal screening of population, and that's one of the questions that had come up. Do we think we should just leave screening to just the people who had high risk, or at every opportunity that you get, why don't you screen? Now, I'm not going to belabor this because Dr. Mithi had talked about who are these high risk patients that we'll need to actually screen for. But in terms of your pre-diabetes, one of the questions that people ask is, who are this category? How do we label them as having pre-diabetes? That means you have a fasting plasma glucose between 5.6 to 6.9 millimoles per liter. If it's a 2-hour postprandial glucose, then it's between 7.8 to 11.1. And if it's an A1C, it's 5.7 to 6.4. And I know part of the problem we've been having is in terms of validation, and you can do an HbA1c, say in KU, you go to Aga Khan, it's a different one, and they have different cutoffs. So it's very important that you actually follow what the guidelines say, because half the time they'll write it's normal when someone has a HbA1c of 6%, and you say that is nothing to worry about, because we are advocating for regular annual checkups. So this is why we are telling you, please look at what we are advising, because we are missing a lot of pre-diabetics. Then the woman comes, gets pregnant, and gets gestational diabetes, yet we could have prevented it, isn't it? Or someone was a resident barely eating, HbA1c of 6%. Then when they become a consultant, they come to me now as having diabetes. So it's something to think about. We have talked about remission of diabetes, and this is clearly defined as a HbA1c of less than 6.5% for 3 months without the use of any medication, that is your oral hypoglycemic agents and insulin. And we actually have quite a number of programs that are currently going on in Nairobi and even Kenya in terms of remission of diabetes. The only issue is we need to actually follow up these patients going forward, because you actually realize it's actually harder to ensure remission of diabetes rather than management. What about prevention? Remember, these are just snapshots. Otherwise, this document is generally 400 pages. I'll really try to summarize. How are we going to prevent diabetes? And this is targeting the pre-diabetic. We talk about lifestyle changes. Dr. Mithia talked about 150 minutes per week, and she broke it down to you very well, but I'll give you some other details that you need to understand when it comes to lifestyle changes. And we're targeting about 5 to 7% weight loss. Metformin has and will always be the wonder drug that we always insist for all our patients, unless not tolerated. Start your metformin, because it has a role in both pre-diabetes and diabetes, and we're targeting people anywhere between the ages of 25 to 59 with a BMI of more than 35, a fasting sugar of more than 7, a HbA1c, remember 5.7 to 6.4, and if you've ever had a history of GDM. Now there's a rule that is now coming up in the studies that have come up that you can actually use pioglitazone, because it's been actually associated with, interestingly, cardiovascular risk reduction. But in a patient who already has comorbidities like hypertension or heart failure, this is probably not the drug you want to use. So in the snapshot, what they said was you need to monitor the development of type 2 diabetes in those with pre-diabetes at least annually. And the concept that I keep being asked this question, what about statins? You go to cardiologists like Dr. Waihenya, and they prescribe the statins for a patient with hypertension. Then the patient comes and says, I read somewhere, I Google, and it can increase my risk of diabetes. What do you do? So you weigh your risk, and that is why we always say individualize your treatment. If I don't give you the statin, and then you end up having an MI, I've actually reduced your lifespan and also your quality of life. So you weigh your options and see how. So even as I maintain the statin, then I'll tell them work on your lifestyle and diet to prevent you progressing to developing diabetes. And remember, if someone is already on it, please don't discontinue. And then for the patients who are at risk of stroke or myocardial infarction, then you consider your pioglitazone. But remember, you have to take into account if the patient is already obese, has elements of heart failure, then you probably don't want to start that medication. Now, one of the speakers, and that was Dr. Mithi, was talking about, we've moved away from the glucocentric approach, and now we're looking at the patient in totality. So we are not saying don't just look at the HbA1c. What we're saying is Stop looking at the numbers, look at the patient. And that is why we put the patient at the center of care. And then we tell you, as the doctor, all you're going to do is educate this patient, then you will be their guide and let them be the doctors. Simply because it's a chronic condition, and today they'll start without complications. 5 years down the line, if we are not screened, they're at the doorstep of a cardiologist, they're at the doorstep of a nephrologist. So if you are at the center, what are the things we're looking at? The key person characteristics. Do they already have any comorbids? What is their age? What is their A1C? Then based on that, you then consider certain specific factors which will impact your choice of treatment. So I'm teaching you why we moved away from the traditional way of giving the medication and saying start metformin, then you move to a TZD and a sulfonylurea, and then finally insulin, is we realize that we have all these nice advanced drugs, but we are not looking and focusing on the patients. Then thereafter, you come up with a DSME, and this is focusing on the patient. Will they be able to sustain this kind of medication, the lifestyle and the exercise? Agree on the management plan with the patient, so you come up with some smart clothes, then you implement it, and then ensure that there's ongoing support. One of the problems we have, especially for the gentlemen, is if they come for a clinic visit without their wife, for sure she believes in the African culture. If I don't feed my husband, it shows that I don't love him. If that pot belly does not grow, that is a sign that we are not affluent, isn't it? So one of the problems, I can't believe the lady I'm saying this, one of the problems is that ladies were insistent on feeding our husbands, believing that is the way to a man's heart is through the stomach. You're not realizing that you're pushing him closer to the grave. So ensure that they've got very good social support in that involve the family. And what we teach them is, if your patient has been diagnosed to be diabetic, why don't you involve the whole family? Remember, these children are also at risk, isn't it? So why don't you start a lifestyle change? I remember when I took my children to school, one of the things they tell us is don't give junk food, and then you're the first one to put a packet of crisps and sticks, and the teacher is like, no, only healthy snacks. So it has to start with us as parents. Give your child an apple rather than giving them biscuits. You understand? And hence the concept of support, so that they're not eating fries as he's eating the small piece of ugali and vegetables. And then keep on reviewing. One of the problems I've noted, which we discussed with the dietitians and nutritionists, is we only send them at the first visit, and then they never go back to the nutritionist. They say, I got my advice at the first visit and I've never gone back. But why do you keep doing that? They keep coming to see you as a healthcare professional. Why should they visit to see what are the challenges that they're experiencing? Now, remember we talked about the patient involved. So as you assess the patient at the first time, think of these comorbids: systemic hypertension, dyslipidemia, NAFLD, metabolic dysfunction associated liver disease, coronary artery disease, cognitive impairment. You'd be surprised that some of these patients are actually, one, they can't hear very well. And if you can't hear very well, then your mind will not, actually your brain will not register most of the information. So these patients end up getting cognitive decline, and you're assuming this is age related, but it's probably because you just never bothered to remove wax from their ears. And then fractures, hearing loss, periodontal disease. Remember Dr. Jackie said brush your teeth, so I hope everyone brushed their teeth. And then hypogonadism and infertility. And another concept is also sexual dysfunction. So that's why they say you need to do a comprehensive medical evaluation and assess the comorbids. What are we talking about? And this is actually a challenge to everyone, both public and private. Why don't you adopt this? That first, very important is your diabetes history. Is it the first time? Have you had it before? Find out about a family history. Then personal history of complications and comorbids. Make sure at that first instance, do they have hypertension? Do they have dyslipidemia? Do they have kidney disease? Do they have eye disease? When was your last dental visit? How many people here actually, if you're at home, you can also raise your hand, have actually sent a diabetic patient to the dentist? Anyone? Anyone? Yeah, at least we have a few. So it's very important that you have to send them, other than the ophthalmologist, the dentist, and then you find out what's been going on with the patient in the interval. Then the eating patterns. Remember, you are what you eat, and we noticed what you are eating over time, no pressure. Then you assess the patients and see. Sometimes I feel like we give them diet plans, and I remember once a patient said I was given a meal plan with broccoli, and the lady was like, I was too embarrassed to ask, but what is broccoli? So you have to actually think about the patient in front of you. Then, of course, your physical activity and your sleep behaviors. So when I'm giving the talk on the physical activity, I'm going to ask you to stand up and then, walk around. And then also the concept of tobacco and alcohol and substance use. What other medication? The problem we have as diabetologists is the polypharmacy. I'll give them medication for dyslipidemia, hypertension, 4 drugs for diabetes, isn't it? Then they have erectile dysfunction, then they're barely able to sleep, then they have arthritis. By the time they're done, a patient is walking around with a handbag and they're a man. Just thinking about that. Huh? And you have to talk. How many of us actually talk about vaccines? And that's why we'll talk about vaccination in our patients, because we have lost patients during this period simply because we didn't tell them to go and get their flu vaccine. This influenza has really hit us hard. And then technology. Just because the patient in front of you cannot afford doesn't mean you shouldn't know about it, because you may get that one random patient who actually wants to use the technology, but you're also not giving them the privilege of using it. So we'll talk a little bit about that. And then your social network. One thing we found is this patient, someone had talked about the role of palliative care specialists. We really need the patient support groups, and I'm really happy that we have organizations where you have patient support groups, because this is a chronic illness. It's frustrating. Once you're diagnosed to have diabetes, you have it for the rest of your life. Even if you reverse your diabetes, you're still a patient with diabetes, not a diabetic patient. And then, of course, food insecurity, now housing. You've seen with the floods how many people have been displaced. So you've taken a history, you've seen how comprehensive it is. Let's examine this patient. Don't just write and say CT management. We know we have clinics of 60 to 80, but at a glance, look at the height and weight of the patient. Just BMI, the nurse, Jerida, height, weight. Estimate BMI or your waist pressure. Try and do that in the clinic. Then check your blood pressure. Endoscopy, we have to give the ophthalmologist work, so we'll send it to them. Then that's also because we don't really know what we're looking at when we're doing otoscopy. Then thyroid, what we are saying it's important to do thyroid palpation is because thyroid disorders come hand in hand, especially the type 1 diabetic patients. And then we have these pre-diabetics who have actual signs that we missed out. The darkening around the neck, under the armpits, which is called acanthosis. That's related to diabetes. The patient presented with it, but we just did not know what we are doing. Skin tags, something as simple as skin tags, tells you that diabetes is knocking on the door. And then visual inspection. It may not be, you should hear the podiatrists talk about how exciting it is when they're looking at feet. But honestly, now, because of COVID, thank God, we wear masks all the time. So please look at feet. Honestly, you'll be surprised at how many diabetic feet we are missing. And then screen for depression and anxiety. Oh, that's really nice. Akunga, you walk around with a monofilament. Yeah, okay. So that's, in fact, one of the things, Amaya, that we'd like to encourage the farmer, Amaya, even as you're not listening, is instead of coming to give us pens and notebooks in our offices, give us a monofilament. I think that makes a better difference. Give us a tape measure, and that will actually make a big difference in terms of how we are managing the patients. And then you want to assess their functional performance. Then labs. Of course, we'll mention HbA1c as one, a lipid profile. And remember, it doesn't have to be fasting, because we use a lot of patients say next visit. That's in a public hospital, 6 months in which a patient has stayed without a statin when they really needed it. I say statin replaced aspirin in a diabetic patients. Your liver function test, at least do a spot urine, albumin, creatinine. You should just do even the urine dipstick. Makes a very big difference. Your TSH if you have type 1 diabetes, and then your B12 if you're on metformin. Now, remember that is just for your initial. Then we talked about comorbids. If someone is hypertensive, and they're dyslipidemic, please do the ASCVD, atherosclerotic cardiovascular disease risk tool. Please look it up. It only takes honestly, 5 seconds. And nowadays, when my patients refuse to take statins, we calculate it with them so that they understand how we are reducing the risk of cardiovascular morbidity. Then you set goals. This is what we're going to do in terms of diet, exercise, medication, and we'll keep reviewing. Remember, there's nothing wrong with reviewing your management. Then you want to assess for hypoglycemia. You cannot talk about diabetes if you're not talking about the risk of hypoglycemia. Why? Because that's the one thing most of our patients are afraid of. So I'll not prescribe to Dr. Betty here, like 4 injections in a day, and I know she's a busy consultant who forgets to eat like 2 meals in a day. For sure, she will just collapse in front of her patients if she's constantly doing 4 times a day injection of insulin. I give her twice a day, isn't it? And then you talk about the elderly patient. In fact, actually, my elderly patients are very happy. You know me, I'm known as also a geriatric specialist because those are the ones who, they don't leave their house. Those are the ones who eat diligently. They have the best monitoring. To treat geriatrics, you understand how amazing it is. But you'll not go prescribing sulfonylureas to them elderly because of the risk of hypoglycemia. They're also osteoporotic. That means it increases the risk of fractures. So I hope you're thinking about what we are thinking when in terms of assessing. You give a young man who's an alcoholic insulin, of course they're going to come with hypoglycemia. Then know when to refer. It's criminal not to send to the ophthalmologist, the dentist, to the gynecologist. Imagine a woman who is having a BMI of 40 and then she says she wants to conceive and she goes to the gynecologist. I mean, she comes to you and says, I'm having issues, and the first thing we say is go to the gynecologist, and he then proceeds to try and help her conceive. Let's first stabilize her to ensure we don't have pregnancy losses and the patient is actually healthy thereafter. Then talk about diabetes self-management, education and support, and don't forget about your mental health professionals. Now, the reason why I put this here is one, to wake you up because it's important for you to know, and that is why I've mixed up my presentation simply because there are things that we keep missing out. Vaccination for these patients. When COVID came, those are the ones who died the first and the most. Those are the patients who ended up getting, if you are predisposed, you got diabetes and it was very difficult to manage. So, which are the ones we're talking about? The flu vaccine. These are the ones that they're at risk of. Influenza, pneumococcal pneumonia, hepatitis B, and HPV. So as per the CDC, this is what they recommend, but we are in Kenya. So let's look at the Kenyan guidelines, which were released in 2023. And we had quite a number of specialists actually involved in this. So for the diabetics, they recommend hepatitis B, even now I'm surprised. Adil, I hope I'm not cheating. So you'll tell me if I've lied to people, you can correct us. Then there is the 23-valent pneumococcal vaccine, your polyvalent meningococcal vaccine, your seasonal influenza, which we do yearly, and your COVID-19 vaccine. That one, because of that recent article about AstraZeneca, we'll just keep quiet and move on quickly. So let's talk about, I hope you got that. Now, about exercise, I want you to pause, think about it, look at this slide, and then now I'll tell you how there's so much more to exercise. And that is why when you have avid hikers like Dr. Jackie here trying to encourage us to climb mountains and you only go to Karura, you'll understand how it's a great service. Let's talk nutrition first, because that is key. We can't go to exercise if we haven't talked about nutrition. I'm not going to go into detail because we'll be here till tomorrow. But the important thing is, one of the problems we have, and I'm sure we have dietitians here, is we always use that concept of the plate model. Half the plate is vegetables, a quarter is starch, and a quarter is your proteins. However, the size of the plate matters. That's one thing I realized. And we actually asked the wives to take photos of the plates, and you find the gentleman always has a bigger plate, and the lady eats only a bowl. So she says because it's a bowl, she can eat 3 times. You understand? And so she ends up eating actually more than the man. So it's important that you sit and work with the nutritionist. In diabetes, we always believe in multidisciplinary management. And then another thing is in terms of energy, if you don't eat, you can't exercise. So stop telling them about these crazy diets where one, it's not sustainable, and then number 2, they don't even have energy to work let alone exercise. But our target is a weight loss of 5%. Then the eating patterns are very important. So we have the executives or the even, let me use doctors. You are the worst patients because number one, you don't eat properly. And when you do, you just eat badly. So first, can you start with you as a healthcare professional learning how to eat properly? I remember when I went to the nutritionist to give me a diet plan, the first thing she said is, oh my God, we have so much work to do. And so we are learning. I'm a work in progress. So it's good you should start today as well. And the concept is don't stop your carbohydrates completely, okay? That's one myth that has been propagated, that carbohydrates equals glucose equals diabetes worsening, isn't it? But remember, the body uses glucose as a source of fuel, source of energy, so you can't completely stop it. The concept is, why don't you avoid the non-starchy vegetables, okay? Then there's a concept of always drinking the fruit juices, thinking they're healthy. But what we realize is the glycemic index for the fruits is quite high. So opt for water. When you're very hungry, even now, the challenge for everyone who will be seated, whether in your house or even here in Naivasha, is when you're very, very hungry, please drink a glass of water and then now go and eat. You'll be surprised you eat less. And then for patients who are having a flexible insulin program, please work out and do carb counting, which is very important because sometimes you'll end up either giving a very high dose or very low dose, and we're trying to avoid the excursions in glucose. Then, when I was in school, we talked about proteins and we always believed, animal proteins, but what we realized is the plant proteins are giving us a problem. Before we'd say give rice and say beans, and most of the elderly patients, even up to today, are still eating that. The problem with beans is what? 85% of these beans is carbohydrates. It also consists of a concept of proteins. Now, what is interesting about proteins is it actually enhances insulin action and secretion. So you end up actually getting a hypoglycemia thereafter because it stimulated even more insulin production. So even when you're choosing your type of protein, please be sure that you worked it out with the nutritionist. At the end of the day, just see the dietitian. Dietary fats, they keep telling you about your monounsaturated and polyunsaturated fats. One of the questions was, is there a role of, say, your omega-3 and all the other supplements? So we go straight to your supplements. You've seen things like insulinol, diabetol. Do you know what they're doing with those herbal supplements? They put a sulfonylurea in that herbal product, and that one we've actually tested. They put a sulfonylurea there. Then a patient stops all the other medication, takes it and says, "Doctor, why were you giving me, medication when it was actually a herbal supplement?" So if before your patient, please educate your patients. I educate your patients that these herbal supplements, one, there can be drug interactions, and number two, don't always believe. Remember, this is just a marketing gimmick. So they've not been shown when you take supplements that there's actually going to be an improvement, significant improvement in your glycemic control. Alcohol. Now the guidelines say drink in moderation. I don't know if you've seen this meme where you say 1 glass of wine a day is good. And then in one, you've seen the meme where there's this huge wine glass. It's almost the size of a bucket. So be careful. As you say moderation, I generally tell the patient, perhaps not drink tea like me. I drink tea. And otherwise, especially for the patients who are diabetic and on insulin, those are the most dangerous. You know what they do? They drink alcohol, useless calories. Then they say, I'm not going to inject myself because of the risk of hypo. So do you see how they keep on having hyperglycemic episodes? Then if they inject in the morning, they double the dose, you get hypoglycemia, and that is the problem. There's a role, remember, most of your diabetics could be predisposed to hypertension, so reduce your sodium intake, your salt consumption. Then your nutritive sweeteners, if you've actually tried them, I've said sometimes before you prescribe, try it. That sweetener, like stevia or canderel, is so sweet that I think I could understand even how the manufacturers came up with its low calories, and it will not raise your blood sugar and still gives you the concept that the drink is sweet. But the trick to it is that it makes it too sweet. The patient will start with one sachet, then go to half a sachet, and eventually then like, I don't really need it. So it's good to prescribe, but remember it's also been associated with malignancy. So something to think about. Okay, now you're looking half asleep. If you're at home or here in the room, stand up. I mean, like serious, I'm not going to continue until you stand up. Stand up and jog on the spot or do whatever you want. But as we talk about physical activity, I'm standing between you and lunch. And Amaya says I have to speak, so you have to stand up. Even Amaya needs to stand up. Yes. So Dr. Mithi talked about 150 minutes of exercise per day, right? Now, with children and adolescents, that's very easy. In fact, that's the best group. We tell them to run around 60 minutes a day, whether it's moderate or vigorous physical activity, that's perfect. But adults, I included, are terrible. You never, and one of the things I did was I got a smartwatch, and the smartwatch, what it does, when you've sat for 1 hour, it tells you you're being lazy, get up, walk around. Otherwise, it keeps beeping until you get up and walk around, and then it will keep quiet. So it's something to think about for those who can afford. And so when we talk about 150 minutes, what we say is 30 minutes a day, 5 days a week. But you should make sure that you don't have more than 2 consecutive days where you have not exercised. And that's why Dr. Mithi said, exercise Monday to Friday, rest Saturday, Sunday, and then pick it up again. Otherwise, you lose the effect of exercising. Then there's a concept of, I remember when I went to a dietitian who they also advise you about exercise. Someone said if you do 10,000 steps a day, that's adequate. But remember, that is just increasing my heart rate just a little bit. There's a concept of one, you need vigorous intensity exercise and resistance exercise. And that's why you actually have to mix it up. Now, for the adults, you at least engage in 2 to 3 sessions of exercise on non-consecutive days. Decrease the amount of time spent in daily sedentary behavior. Amaya has made us sit here for 5 hours, so I had to make you stand. It seemed really fair. Prolonged sitting should be interrupted every 30 minutes. So we should have made you stand up, you know. I don't see anyone jogging on the step. At least try and raise your, you know, you should actually, if you're in your house, get your children to even jump up and down with you. And then flexible training and balance training is very, very important. How many have actually done yoga? One is very good for your mental health, and then also flexibility. You should try it. And nowadays it's even online, so it's actually cheap. So can you please try and think about that? So one thing I want to introduce is the concept of body fat composition. What we found is I have 3 patients who all they do is walk up to 20,000 steps a day, but never lost a single kg. You know why? Because what is that? Is that high intensity training? Your body adjusts to that and it becomes your new normal, okay? And that's why you have to introduce resistance. So he said, continue with your walking, but in between try and introduce swimming, try and introduce 10 minutes in your day where you're jumping up and down, doing your jumping jacks and your burpees. That actually makes a big difference. And then just promote non-sedentary activities. So we'll make sure you walk all the way down just to be able to eat your lunch. And housework is actually important for those of you who have 3 or 4 nannies. Once in a while, it's good to help them. Gardening is also good for your mental health. And then dancing, I think we should dance, don't you think? Yes, good night and sit down. But wasn't that a good break? Yes, once in a while, I saw you yawning and it seems not fair. Seeing as I'm the last speaker of the day and I'm telling you all that you need to do. Good. For smoking, now the problem we have is those are conventional cigarettes, which now, surprisingly, the ladies are leading in it instead of the men. So that's something we really need to, I think we're missing that concept of educating the young girls in school. There's so much peer pressure that we seem to be getting lost in translation. And then there's the concept of e-cigarettes. They're told it's less tobacco. Tobacco is tobacco. It puts you at risk of malignancies. And you know, quite a number of our diabetic patients are at risk of cancer, so you have to screen. So when I've told you about exercise and diet, before you go to the drugs, you need to have a target, right? So I want you to look at the concept of continuous glucose monitoring. Now, what they found was if a patient stays within a range of 4 millimoles to 10 millimoles a day for up to 70% of the time, we found they had less microvascular complications, okay? and you spend less time either above the 10 or below the 4, again, less micro and macrovascular complications. Because so one question we asked was, we targeted HbA1c, they come with good HbA1cs, but they're still amputating the foot or dialyzing. Then we realized we were missing the boat by focusing only on your HbA1c. So the guidelines say is, one, for a non-pregnant adult, you target HbA1c of less than 7%, right? Because with the pregnant patients, it's tighter. Then if you're going to use the glucose in terms of self-monitoring of blood glucose, maintain a timing range of up to 70%. And that's where your continuous glucose monitors come in handy. And I'll show you one as we talk about the new devices. And you spend less than 4% below range, and even less than 1% below 3 millimoles, because that hypoglycemia portends an increased cardiovascular risk. But remember, for the elderly, don't be so strict. If you're too strict, risk of falls, risk of fracture is high. So think about that. Huh? So when we say a target of 7% for the elderly patients, I don't know where elderly is. According to WHO, above 85, me, I'm still youth. I'll remain youth for 20 years to come. So I don't know about the rest. Then remember, the point of reassessing is my target was 7%, right? However, the patient is motivated and wants to undergo diabetes remission. If they've had diabetes less than 10 years, they can undergo diabetes remission. So if you started with insulin and OHS, downgrade to oral hypoglycemics, again further downgrade to the point where they're doing diet and physical activity. So keep reassessing based on the individual. If they're motivated, please go ahead. If they're not, please don't bother. And that's why we've shown this repeatedly. And the concept behind this was, you want to target an A1C, but who do you be tight with and who do you not be tight with? So we look at, do you have a risk of hypoglycemia? And if it is high, you've had a long-standing disease duration of diabetes. You have a short life expectancy. If you're telling an 85-year-old they have to get an A1C of 6.5, the problem is you, the healthcare professional. If you already have CKD, heart failure, then, and your patient is like, me, I don't want to, just give me one tablet, that is enough. And they, of course, have limited resources. Don't be so strict. They're probably not going to comply. So in such patients, you'll actually worsen the cardiovascular risk. So they tell you, please don't be so tight. And the converse for those ones who are able to handle it. So when we talk about why we say you need to individualize, it's because of the risk of hypoglycemia. It's very important you identify and classify this hypoglycemia. Is it a hypoglycemia of less than 3.9? Level 2 is less than 3? Or level 3, the patient has come and is comatose. That means probably your sugars are even below 2 or even 1. Don't even discuss first, correct it, then now you figure out what is causing it. Then look at the complications. We're talking about comorbids, right? So one of the things most of our diabetic patients is, and that's why it's pertinent and it's one of the comorbids are put up first, is the non-alcoholic fatty liver disease, because these patients are progressing to fibrosis and cirrhosis and they have a high risk of hepatocellular carcinoma. So if you have a diabetic patient, hypertensive who's obese, and you do the liver function test, you start to see an elevated gamma GT and alk-phos, then send them for a fibroscan. If you find that when you've done the testing, they're at low risk, you can repeat that after 3 years, it's expensive. In the event that they're intermediate or high risk, I tell people just go straight to the gastroenterologist, because after all, they're the experts. But what's the concept behind the fatty liver disease? It's because you want to control the obesity, hence we move to obesity. What they found is if you lost up to 5% of your weight, it improves your glycemia. But if you lost even up to 10%, we're reducing your cardiovascular mortality. So before you see we're talking about numbers. HbA1c, sugar. But it's not just about sugar. Look at the patient. So if you're telling me that it reduces my mortality, I'll focus on weight loss even more. So what's the concept? If my BMI is between 25 to 26.9, we'll talk about diet, physical activity, and we'll counsel them about maintaining. If your BMI is between 27 to 29.9, Other than the above, diet and physical activity, we start talking about pharmacotherapy. Because we found these are the ones we're talking about, pre-diabetics and diabetics, because we'll actually reduce the number of drugs you're giving them. And if your BMI is more than 30, please consider surgery, because these are the patients who be on 4 oral hypoglycemics, on up to 100 units of insulin, and you don't know what to do. So those are the drugs available. What we found was the first 3 were associated with such severe side effects, and when you stop, then you end up right back where you started. Similar with these last 2, but what we found is these last 2 are associated with reduced cardiovascular mortality, and that's why we keep talking about them, other than for reduction in obesity. So let's talk overall. Someone had talked about if you have a diabetic patient, what do you do? We've talked about diet, we've talked about physical activity. So let's talk drugs. Wake up just for 5 minutes, actually more than 10. So the concept is we talked about diet and exercise. Then we risk stratified, and that's why we removed that. We say diet and exercise. Can they tolerate metformin? Yes. Then let's risk stratify, and this is part of Dr. Jackie's talk at 10 minutes. If you have atherosclerotic cardiovascular disease, then or heart failure, you start thinking GLP-1 analogs and your SGLT2 inhibitors. I'll not belabor the point about chronic kidney disease because you talked about it. SGLT2 inhibitors. Now, the problem I have with these guidelines is it says that the eGFR is less than 60. And what we are saying to the nephrologist is, could you perhaps consider even starting it earlier? If you're saying it's retarding the progression, we know that they could already be having chronic kidney disease. It's just that we're not able to pick it, isn't it, with our labs? So it's just something to think about. Then we talk about now the weight management. Remember, we're still talking about obesity. So when you talk about weight management, we'll talk nutrition, we'll talk about physical activity. Then we look, is this patient with a BMI of 27, 29.9, telling someone who has a weight of 90 and you want them to get to 65, surely, with just diet and exercise, is just not fair. Okay, and they're already developing early signs of arthritis. So consider in the interim, remember all these drugs, when you stop, you put the weights back right on. So what we have, we don't have tirzepatide, but we have semaglutide. And please, in consultation with the endocrinologist, we can advise you on, because there's both the oral and injectables. Then if they can't afford, then there's liraglutide, which you can actually use. Now, other than that, the question is, where do we put insulin? If all else fails with the oral hypoglycemic agents, what do you do? Put insulin, right? But remember, there's some people who we start directly with insulin. Who? If your A1C is more than 10%, if you have features of catabolism, have you ever got these patients who come newly diagnosed, sugars are 30, then they say, I've lost 15 kgs. The woman is so excited, but so tired. That's a bad thing, because it means that because you don't have enough insulin, the body has switched from using glucose to the fats, and that is why you end up losing the weight. If you have ongoing ketosis for pregnancy, protect the mother and the baby. See, as gynecologists, we work well together with you. If your A1C is more than 9% and you're already on 3 or more H's, stop flogging the dead horse. Give insulin. So at the first time when you meet a patient, tell them this is disease. If I start talking about insulin, it's not that you fail, it's that you just need the insulin because your disease has progressed. If you have severe organ involvement and your perio patients. So when you talk about insulin, of course, that's where type 1s are. And now we change the guideline. Before it used to be, and I'm really hoping that all of you who are online and here will take this as a take-home message. Stop prescribing premixed insulins to patients with type 1. It's just not fair. It should be multiple daily injections, because remember, every time you eat, everything is converted to glucose. Glucose can't enter into the cell without insulin. The thing about your premixed insulin is they say it has a half-life of up to 10 to 12 hours, but at some point, you know for sure that there may be no insulin in the body, depending on how the body breaks it down, the pharmacokinetics. Number 2, you're going to have peaks, isn't it? Breakfast, lunch, dinner. So why don't you mimic the normal homeostasis? And that's why we say, to reduce the concept of hypoglycemia, multiple daily injections. And then you match it with the meals that you're giving. Stop telling them to stop their carbohydrates completely. And when we talk about the age and the characteristics in terms of type 1 diabetes, we start thinking of how you're going to distinguish one who has diabetes at an earlier age or a later age. Then these slides have become someone else's slides. Am I? This one. Are they telling me to stop? I'm not going to stop. These are not my slides. Cancel. Someone decided to change my slides and introduce pathogenesis, and I will continue to talk. When we're talking about the concept of type 1 diabetes, you have to have multiple daily injections simply because we need better control and we need less glycemic variability so that we can be able to manage the patients adequately. When we talk about monitoring, and let me just talk briefly about what is called the continuous glucose monitoring. The problem we've been having is patients keep feeding themselves. So imagine you feed yourself for insulin and you feed again. Actually, the feed for glucose is very painful. So they came up with the concept of continuous glucose monitors, where they get a device which you can attach and measure the interstitial blood glucose level, and they check it against your plasma glucose level, and they found a very big variation. Now the concept is that you will attach it subcutaneously, then thereafter, all you have to do is link it via Bluetooth to your Android phone. And anytime you want to measure, you tap your phone to the device and it measures. And it measures the glucose every 5 minutes. What's amazing about this continuous glucose monitor is that one, it tells you the glucose level, then tells you the average daily glucose level, average weekly glucose level, average monthly glucose level. Okay, that's one. Number two, it tells you how many episodes of hypoglycemia, how many of hyperglycemia. And it tells you when it occurred. So if imagine a type 1 who injected and then keeps getting hypos at 2 a.m., but it doesn't, the patient doesn't sense it because it's not too low to warrant you to wake up. You understand? And so you're wondering why this A1C is not fully controlled or why the patient is getting complications. There is your answer. Patients with pre diabetes, there is your answer. In your patient who has type 2 diabetes, you're putting them on orals, but then they're like, I don't see the point. And you want to figure out, is it that the diet is the problem? Because you know, sometimes patients come and you keep on adding more and more drugs, isn't it? Then you'll discover, you give them a sulfonylurea, they get hypo, and then because of that, they compensate and they eat even more. And so that is the problem that we're experiencing. Yes, that is it. So because of that, that's the concept of continuous glucose monitoring. Now we have what we call the artificial pancreas for type 1 diabetics, where what you do is you connect an insulin pump, okay? You attach it to the patient. And then you have your continuous glucose monitor. Yes, and that's why we call it artificial pancreas. The monitor will sense the glucose, send the message to the pump calculates the dose, and voila, you don't need to do anything. And that's the concept behind the artificial pancreas. Even if you're like 55, I will go back. Yes, so that was the concept behind the CGM. But just slowly, what is coming up and what is new? So the oncologists and the rheumatologists keep talking about the monoclonal antibodies, yes, as a way of actually preventing the progression of the cancer. Now, what we've got is the use of monoclonal antibodies targeting. Remember, type 1 is an autoimmune disease, right? And we test for GAD65 antibodies, insulin autoantibodies, zinc transporter 8 antibodies, isn't it? So what if we targeted, if we know at high risk for children below the age of 8 years, and we don't want them to develop type 1, if we gave them, say, a drug like teplizumab, would it actually prevent them from developing the diabetes as early as they do? So that's what is going on currently. I just thought it would be good for you to know that there are exciting things coming up even for our type 1 diabetes patients. And this was the artificial pancreas, the closed loop system. Before, if you had just the pump, then you'd have to feed and then you have to calculate the dose and then inject. But you see how smart it is. It's attached, it measures the glucose, then works out the dose and you don't have to do anything. Isn't life good? It just costs 500,000. So it's something to think about. Then let's quickly go through the complications now that I'm left with 10 minutes. Is one, look at the pillars for managing diabetes. Reduce your HbA1c, control your glucose, control your pressure, your lipids, and your chronic kidney disease. Jack, we talked about chronic kidney disease, and be good. So for hypertension, and now I'm just going to quickly go through the main targets. Your target for BP, less than 130/80. Okay, not 140/90, not 131/82, 130/80. No benefit of going lower. If anything, you increase their cardiovascular risk. What are your options? Remember, most of them come with CKD. So the concept is, we look at, could they be having albuminuria or CKD? See, now the cardiologists are now looking before they were closing their eyes. The concept is lifestyle, diet, then start one agent and see if that works. And the preferred agents are your ACE or ARBs or your CCBs. So this is where your combinations come in. So the combinations have ARBs and calcium channel blockers. Use them. Why? Because even in your CKD patients, CCBs have an element of reducing your proteinuria as well. Not as well as the ACE inhibitors, but it can. If you find it's still not well controlled, you've used your ACE or ARB, you've used your calcium channel blocker, then use your diuretic. If you find it's still not well controlled, then you use your mineralocorticoid receptor antagonists. Okay. I don't see anywhere where there's beta blockers. So can you please stop using beta blockers for management of diabetes unless the patient has coronary artery disease? I said the right thing, right, Dr. Hen? I didn't lie. Lipids. Lipids, I know, is still in the era of cardiologists. But the concept is anyone above the age of 40 should be on a statin. You give statins to diabetics the way you used to aspirin. You understand? Please stop giving aspirin for a patient has never had any cardiac event. It's only used for secondary prevention. For the statins, remember you have to give a moderate intensity statin and you're targeting an LDL of less than 2.6. If you're the age of 40 to 75, you have one or more risk factors. Use a high intensity statin because you're targeting an LDL of 1.8. But I caution you, the problem of having targets which you tell patients is that when they reach the target, what will they come and tell you? Lakini daktari si nimefika. Then why don't you stop? No, you can reduce the dose, but don't stop. This is a lifelong therapy, isn't it? So even when you start, tell them I'm not stopping after 3 months. And remember, even for the elderly, having symptoms of myalgia, please don't stop. These patients are living up to the age of 100 so that they can see Dr. Ngugi. Give them that privilege kindly. Then remember, if you've given them a high intensity statin, it's still not working, then you can add ezetimibe or PCSK9 inhibitor, which Dr. Jackie had talked about. And this is how the concept between high intensity and moderate intensity is its ability to lower the cholesterol. If your LDL is lowered by more than 50%, this is a typo, should be atorvastatin 40 to 80 milligrams and rosuvastatin 20 to 40. Moderate intensity lowers LDL by 30 to 49. The ones we commonly use are the atorvastatin and rosuvastatin at those doses. Okay. So I'll take you back a little. We talked about obesity, we talked about hypertension. What if a patient now, because of having all these conditions, is at high risk of atherosclerotic cardiovascular disease? Optimize blood pressure, hypertension, lipids, blood pressure and lipids. Then and remember, one of the drugs you have to give is your SGLT2 or your GLP-1. That is why we say it's not for everyone, give it specifically. And I leave you with this reduced cardiovascular risk for a patient with cardiovascular morbidity. That's the only time you give aspirin when you've already had events like stroke or an MI. Please, 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 if you're listening to this one of the take-homes, don't give aspirin for primary prevention. Diabetic patients, diabetes is a coronary artery disease equivalent. Give high intensity statin. Stop giving them atorvastatin 10 milligrams. You're not doing anything for that patient. They need high intensity. Your beta blockers, if you have coronary artery disease, stop smoking. ASO ARBs and SGLT2 and GLP-1s. I will not talk about CKD because Dr. Jackie has talked about it, including even the use of finerenone. And then finally, Jackie's one slide, neuropathy as one of the complications because it wasn't covered. Think of the gabapentinoids, serotonin, norepinephrine reuptake inhibitors, and your TCAs. Do you see B12 replacement here? No. So can you stop prescribing whatever it is that you prescribe unless you have actually screened the patient and checked for B12 level? They have been on metformin for more than 4 or 5 years, and that is causing the B12 deficiency. Actually, just give the patients what they deserve, the right medication. SNRI, the duloxetine and the venlafaxine, TCAs are things like your amitriptyline. You've seen that they gabapentinoids with your TCAs, and then of course your capsaicin. And then finally, it's good to know the reason why we like these drugs and why we like diabetologists is our drugs are not just for lowering the sugar, has other benefits. And that's why the nephrologists and cardiologists wait for us to discover the drugs and then they try and steal it. But it's fine, we like to share. And finally, I want 1 minute talk about the guidelines. You know, one thing we realized when we were coming up with the guidelines for Kenya is we have this big book, 400 pages. People say, oh, please share the guidelines, and then no one ever reads it. So we've made it easier. We worked with Ministry of Health and quite a number of the partners collaborating. And what we've done is come with literally the diagrams. You have a GDM patient, this is what you do. Your hyperglycemia is literally a flow chart. And we're going to launch this at our annual conference, which is in Pride Shanzu. Come and see what we have in store for you. Your life easier. And what we plan to, sometimes we come, we sit here in Naivasha for we come up with all these protocols, and then we don't make sure that we take it to the grassroots. So we are actually going to go around all 47 counties in collaboration with the Ministry of Health, taking you through each of those protocols, both outpatient, inpatient, and even for type 1, so that we care of diabetes in this country. And so I really want to thank you, Ethica, for this opportunity, for talking about how we can be able to improve. This is a CSR event at the end of the day, but the most important thing is the ensuring that this education, and my chair has come. So, okay, thank you very much for your attention.
Rosie has taught us the Kenyan thing of using in conclusion to join the first 1 hour with the second half hour of the presentation. I think what this shows is that diabetes is very complex. You cannot compress diabetes in even 1 hour. So maybe we need to do more of this educational thing so that we can cover the various topics nicely. So we want to thank everyone for attending. I see we still have 756 people online, which shows that, and we had a total of 890, which shows that this is something that people needed and this is something people are interested in. And we hope to do more of this frequently with Group Ethica or with anyone else. And everyone can also go back to their own homes and do small CMEs in your own homes, so that you can teach people. So I think we'll take a few questions, and I'll try and do just 2 questions for everyone in the interest of time. And I'll start with a question for Olive. Yeah. A question for Olive, and this was on insulin. Okay. The question has disappeared. So, sorry.
When you trace it,
Okay, no. The question was on insulin initiation. When you have a patient who has type 2 diabetes and is 60, how do you decide which insulin to use? And when do you consider stopping the insulin? I know it's a wordy thing, but if you can just summarize in maybe 2 minutes what to consider.
all right. So for insulin initiation, as we had said, the current guidelines recommend that you start with your basal insulin. And the reason we saw is because you're trying to mimic your pancreas at the end of the beta cell function as much as you can. So you start with your basal insulin, as you said. You may remember the slide that had regimen 1, 2, 3 for intensification. So we talked about the recommended starting dose. If you don't remember, most of them 10 units per kg body weight to start with is safe across all the basal insulins. If you want to calculate specifically, we said if your A1C is around 8, then you start at 0.1 to 0.2 units per kg body weight per day of your basal. Okay, and then now you titrate that upwards. The studies have shown that in as much as for some of the molecules of your basal insulin, they say do 2 to 4 units twice or thrice a week. Actually, the compounded studies have shown that an average of 1 unit escalation per day is safe across, even for your ultra long acting insulins. So, you know, sometimes it's easier to break it down so that in practice you can remember. So that's the rate at which you will start. For that particular patient, again, we said you will escalate looking at your fasting blood glucose with a target of around 4 to 7. For the 60s heading to geriatrics, usually around 7 is allowable. For the younger patients, fewer comorbidities, then you want to be a bit tight on that. So once you titrate upwards, remember again, do not over-basalize. If you still have spikes in your mealtime insulins, then you can introduce your short-acting insulins. When do you stop? I think that question had been asked before, depending on your clinical targets. If you're not achieving target, it is in your best interest to advise the patient accordingly. If you're achieving, but also dipping in terms of frequent hypoglycemias, you can consider a step back. I hope that's clear.
Then you can give Dr. Rosie the mic. So I have 2 questions for you. One of them is from Elizabeth Maina, a patient who has been on metformin and benzamide for 20 years, and all of a sudden it is not working now. What should you do?
Thank you, Elizabeth, for that very interesting question, because that is exactly what is happening in all our public facilities. It's not that the metformin and glibenclamide were working for the last 20 years. It was because you were not following this patient adequately and reassessing them. Let's be honest. Let's call a spade a spade. By the time you've been diagnosed to have diabetes, 50% of your cells have been destroyed, the beta cells. Every year, 5% of your cells are destroyed. So in the next 10 to 15 years, you don't have any beta cells. So when you give metformin and glibenclamide, aren't you flogging a dead horse? So what's probably been keeping this patient well is the diet, actually, and the physical activity. This is a patient who should have been commenced on insulin, realistically, almost 5 to 6 years prior to this. So that's why we always enforce, if your patient cannot come every 3 months, or even when they do come after 6 months or annually, please reassess whether you'll use your HbA1c or you'll do a simple urine dipstick that tells you this patient is now developing albuminuria, or you'll assess and ask about their eyesight and you see that it's failing. That tells you they're getting complications. That tells you that your drugs are no longer going to be useful. And this is a patient who should honestly be on insulin.
And I think the final question for you on vaccine. For a patient who is sexually active, has diabetes, what is the criteria for starting them on the HPV vaccine? For giving them the HPV vaccine?
Hey, that's an interesting one. Can I ask the infectious disease specialist to answer that one?
Okay, we have Dr. Adil from Aga Khan will tackle.
So the HPV vaccine ideally should be given as early as possible before onset of sexual activity, because its work is to prevent. Once you have been infected, then it really doesn't work in preventing disease. So the recommendation is when girls reach the age of 9 to 13 is when you should start. But now you can always also test and see with HPV. If it's negative, you can still vaccinate up to 45.
Yeah, and I think just a quick one, the concept behind that, you cannot give the HPV vaccine unless you've actually tested. And it's also because of the risk of cervical cancer. Now we are finding quite a number of diabetic patients are at risk of cervical, endometrial, lung, breast cancer. So just because of the concept of malignancies and also their increased risk of infections, I think it would be important to first test, right? before you give the vaccine?
Yeah, so if you can test, it's good,
Yeah.
but just tell the patients that that it does not like prevent disease if you've already been infected. So the current vaccines we have the bivalent one, which prevents the ones which cause the highest amount of cancer, that's 16 and 18. And then we have, so that's the Gardasil, that's the Savarix. And then we have Gardasil 4, which will do the 16, 18, and 5 and 11. So it will prevent the ones causing cancer, but also preventing warts. And then the other one we have is Gardasil 9, which has more of the serotypes, which will cause cancer and also warts. So that's the best one if you can give your patients. But I mean, the recommendation is up to 26 years of age. But for those who are above that, then you can do shared decision making. It's better to test if possible to check that they've not already been infected with those types. Because I mean, if they've already been infected with 16 and 18 and you're giving them Savarix, then there's nothing really you're doing.
Since you have the mind,
Yeah.
don't certainly ask the COVID-19 vaccine for diabetes.
No, yeah, not that I've seen any data on that one. So briefly about vaccines, I think it's very important. We don't vaccinate our patients, and right now COVID has taken a back step in influenza, is really causing a lot of morbidity and even mortality. So it's important to vaccinate all our patients for influenza, especially those with cardiovascular diseases, diabetes, those who are elderly, pneumococcal as well. So the pneumococcal vaccine, which is available, I saw you said PCV 13 and then PPSV 23. The guidelines have moved on to PCV 15 and then PPSV 23. PCV 13 doesn't really feature, or PCV 20. Unfortunately, we do not have PCV 15, 20, or PPSV 23. The only thing we have is PCV 13. So what we do is just give them what we have, but hopefully I've heard that we are going to get the PCV 20 maybe next year. So that's a one-off. You just give your patient. COVID is important, but as I said, it's kind of taking a back step, and even people are not vaccinating. So even the vaccines are going away. But I think the vaccines have done the work, because now we have natural immunity as well because of repeated exposure, and the virus is probably becoming, like, as it mutates, it's becoming less and less virulent, but we're still seeing a case or two here and there. So always something to keep at the back of the mind. But I mean, if the vaccines are not available, you can't do much. Yeah.
During the second vaccines or whatever. So do they need to repeat and then this clarify for us that don't need? I know there's some that will do. It's not clear to me. Yeah.
Yeah. So if you have received PCV before, then you might not need to repeat, but you still need to give PCV 20, which you do not have. So right now the guidelines have moved to PCV 20, which hopefully we should get next year. So what we should try to do is give all our patients PCV 21, and that's one and done. Yeah. So it's once, and then you give after 1 year PPSV 23, which you don't have. So even if you have given PCV 13 in the past, after a year, you can give PCV 20. So once the PCV 20 becomes, so right now you can give PCV 13 to all our patients. When the PCV 20 becomes available, then you can just vaccinate all the patients who haven't received PCV 13, and those who have received, you can give after a year. That's it. Yeah, flu vaccine is yearly. Yeah.
Sorry, for my knowledge,
Yeah.
is it coming as a single PCV 20, or is it coming, because now it's been given in the DTAP? I think it's the combination that we have.
So no, the combination has PCV. Is it? It's not part of the combination. It's a single vaccine.
Or it's coming singular as PCV 20.
Yes.
Thanks.
Yeah. So hepatitis B. I think the increased risk is for those who undergo like assisted glucose monitoring, because you can imagine maybe a shared glucometer and then they're just getting like pricks, and that might transmit infection. So it's good to get your hepatitis B vaccine. So the dose is the same, 0, 1, and 6 months. Yeah. Also, it's important because we can see our diabetic patients probably have a higher risk of going towards end-stage renal disease. And by the time you have end-stage renal disease and you're vaccinating for hepatitis B, the take is not as good for vaccination. So if you can vaccinate them earlier, then before they get to end stage, then it's better for them, because you can see that they'll be on dialysis and at risk for hepatitis B infection as well.
So the other question I see, how soon after initiation of SGLT2s do you see a decline in the GFR? So after initiation of an SGLT2, anywhere between the first 2 to 4 weeks, you may see a decline in your GFR. And usually this may take sometimes up to 12 weeks to recover. So you should monitor if you're able to within the first month. And after that, you can check after 3 months. But of course, in between, remember, at the end of the day, we still have our clinical signs and symptoms. If you see a patient clinically deteriorating, that's someone you may want to monitor more closely. And I think the last question I will answer here is studies show that some statins can raise your HbA1c in some patients. So what is the recommended approach to treatment of dyslipidemia? It is true that that has been shown to happen sometimes, but the recommendations are do not stop your statins, because at the end of the day, the statins still have benefits. So yes, monitor your HbA1c. And then now this is again where, remember, the lifestyle modifications come in, your nutrition, your exercise, and all, and try and keep the patient on the lifestyle modifications, monitor the HbA1c, and don't stop the statins, because at the end of the day, the benefits you're getting from that statin far outweigh the risks. So
I have a question.
yes.
It's about triglycerides.
Yes.
So statins really have a minimal effect on triglycerides, but most of our patients on statin, they still have elevated triglycerides. And I see there is this icosapent ethyl, which was shown to reduce the triglyceride levels and reduce cardiovascular like events in this kind of population. Is there any, like, I know it's a very expensive drug, is it available locally, or any hope of it?
I don't even think it's available locally. Anyone who brings it probably brings it as a person. I think even the PCSK9 inhibitors are very effective when the statins don't work, or for patients who are having many side effects to the statins. But the issue is availability and cost. So yes, they're effective, but cost is an issue. But especially with triglycerides, you find exercise. You'll find for LDL, it's been proven that as much as you do exercise, it may not necessarily impact your LDL as much as the others. But for triglycerides, apart from the medication, you'll find even the exercise will have a good impact on your triglycerides.
I just want to make a comment in response to your question. First, when you're looking at triglycerides and you find they're elevated in a diabetic patient, that also tells you about their diet. Essentially, what happens is when you have ingested, everything's converted to glucose. Whatever you don't use, it's stored as glycogen in the liver. Whatever is not used is converted into your free fatty acids, and that is how you end up with triglycerides. So that one should tell you the patient has a high starchy diet, high carbohydrate diet. So one, start working on their diet, because probably that is the problem. Number two, exercise, like Dr. Jackie has said. And number three, if your statins are not working, then also an option is your fibric acid derivatives. Your fibrates can actually assist with lowering your triglycerides. But part of the reason why I do lipid profile for my diabetic patients is because it tells me about their diet. If they have high TGs, that patient is cheating, and cheating a lot.
Thank you. I don't think we can finish all the questions. We'll try and answer as many as we can online. But also for the people who have registered online, a lot of you are asking for the slides. It may take time to give you the slides, But what we have done is we have put a link online to the YouTube. Yeah. KNH Research YouTube, and the whole symposium will be loaded there. So even as you're waiting for your slides, you can actually access it and watch your slides and do reviews. So I want to thank everyone for attending. Thank you for being awake and alert for the last few hours, and I hope you've learned something. And what I'd like to encourage you is don't go sit on this information, go to CMEs, go to discussions, make sure you pass on this information to people who are in your facilities so that everyone can have the same level of knowledge as you. I also want to thank Group Ethica for this opportunity to learn, and I think I will now hand over the mic to them.
So again, it's Dr. Maya. Thank you guys for being here. This meeting has taken us like 4 months to organize. We really appreciate those who are supposed to count properly. It is around 890 plus 30 who are here. Oh, so that is around 900 and something. Lawyers don't count children and people. So thank you guys for coming again. And the next session, the next forum will be on the May 18th with the Kenya Renal Association. This is really going to be a very informative. Main questions we get about what do we do when we have kidney function that is deranged? Do we salvage it? Can we reverse it? The patients who require a kidney, or do they require dialysis? What are the numbers of patients who have actually lost their kidneys? And please, guys, let me say this, it's going to be a very engaging one because it's one of the first renal guidelines presentation for Kenya. So please don't miss out. We'll have a very engaging team from Dr. Jonathan Wala, the head of president of Kenya Renal Agency, and various nephrologists. So they will really divulge and dissect the kidney for us to understand. Thank you again. Please register for the CME. I'll put the PDF on the chat. And for all who have attended online, all 900 of you, plus physically, thank you guys, and see you on the next one. Thank you.